this slide over and over again to highlight how we can go through methodically to try to arrive at a high confidence diagnosis of a specific ILD for many of these patients. We're going to start with history and exam. This is really designed to look for a cause for your ILD and really hunt for why that patient is coming in with interstitial lung disease. The other thing that this is designed to do is assess if there's any other comorbidities that could be causing this patient's presentation and look for other culprits to kind of elucidate their etiology. So I think one of the things to kind of keep in the back of our minds here is that even in ILD, common things happen more commonly. And the vast majority of us, regardless of where we practice, are probably going to encounter 4 major types of interstitial lung disease. This includes IPF, HP, connective tissue disease, ILD, and sarcoidosis. And as many of you already know, the history is going to vary greatly for these 4 more common interstitial lung diseases. Even when we step back and we look at all ILDs that we might encounter, all 100 or so, what we realize is that the history is really key in helping us figure out whether or not there's an etiology or risk factor driving that ILD. As you can tell from algorithms like this, if you can figure out why the patient has interstitial lung disease, you can greatly help narrow your list of differential diagnoses. So a history is very key, but a thorough history takes time, and over half of your initial patient visit is really going to be invested in asking very kind of esoteric questions about how that patient lives and what exposures they might have had. And these kind of silo into 7 major buckets, which includes exposure to select antigens that might be in mold, birds, occupational history or select hobbies, certain medications or a history of thoracic radiation, smoking history, family history of ILD, and then really using your review of systems to target a connective tissue disease eval. If you can find a risk factor for that patient's interstitial lung disease, as you can see, you might be able to see if they have a higher pretest probability of having HP, occupational ILD, familial ILD, etc. How you ask these questions is also very important. You don't want to just walk up to the patient and say, do you have bird antigens in your home? Rather, you want to ask, do you have down feather bedding in your bedroom? Do you have down feather throw pillows in the living room? Do you have down feather couches, which are not uncommon these days? Do you have any pet birds? Did you ever have any pet birds? Do you still have the bird paraphernalia like blankets or bird cages that might have the antigen laying around the house? Do you even have stuffed birds mounted on your wall? And while this is extremely tedious and time consuming, if you get a yes to one of those questions, you can imagine how that'll change your differential diagnosis rather quickly. Exam in interstitial lung disease is really there to corroborate your suspicion that the patient has ILD by listening for things like crackles, but it can also be used strategically to figure out if your patient has connective tissue disease signs, some of which are shown on this slide and some of which I suspect will be discussed later today as well. A quick note about sarcoidosis: it is one of our more common interstitial lung diseases, and the skin is the second most commonly affected organ system for these patients. So screening for things like lupus pernio or erythema nodosum can sometimes help you narrow in and hone in on that diagnosis of sarcoid. And then last but not least, your history and exam should really be there to hunt for other comorbidities that could be causing that patient's presentation, which again is very nonspecific and includes things like cough and dyspnea. We also know several comorbidities such as cardiovascular disease, VTE, cancer, PH occur at higher than usual rates in interstitial lung disease patients. And we also know that screening for these comorbidities and treating them aggressively can greatly influence how you manage that patient down the road. And then beyond history and exam, the next really key group of things to consider are select testing. And these silo into 3 major buckets, and they're all designed to really, again, hunt for a cause for your ILD, but also to pivot a little bit and start figuring out how severe the ILD is. So the first kind of big group of testing you want to consider are sending off for select labs. And as you can tell from this slide, many of these labs include connective tissue disease serologies, but others include things like ACE, vitamin D levels, HP panels. One quick note about all these tests, as I'm sure we'll learn throughout the day, is by themselves, they mean absolutely nothing. Just because your patient has an ANA that's positive doesn't mean that they have connective tissue disease. It only means that if it can be supported by their history, exam, and other non-invasive workup in the context of a multidisciplinary discussion. Genetics in ILD is complicated, and we know this because most of us don't know any of the algorithms or mnemonics on this slide right here. And other than that, I think from a ruthlessly practical clinician standpoint, what's important to take away from slides like this is that we now know there's mutations that are associated with sporadic forms of ILD as well as familial forms. Some of these mutations occur in patients with IPF, as you can tell, but now we've also discovered there's mutations in non-IPF ILD. And some of these mutations are associated with short telomere disorders while others are not. And this can get very confusing very fast. And again, from a very ruthlessly practical clinician standpoint, I think there's 2 big groups of patients you want to at least identify in clinic. One is highlighted more so in blue at the top of this slide. This includes patients with a family history of ILD. And that's classically defined as having 2 or more first-degree family members with interstitial lung disease. These are patients you might want to refer to your local genetic center to consider for mutational testing. There's a second group of patients that we don't want to miss, and those are highlighted in pink on this slide. And those include patients with short telomere disorders, which not only present with things like ILD, but you also want to screen if they have a personal or family history of early cryptogenic cirrhosis, aplastic anemia, premature graying of nearly all their hair around or before age 30. These are patients you might want to consider sending to a center capable of doing telomere testing on, and depending on the results of the telomere test, the center might also refer them for other mutational testing. And then the last group of testing beyond labs and beyond genetics testing is really bread and butter, full PFTs and walk tests. These really do help you establish how severe the ILD is, but as you can tell, they're going to come in handy down the road as you manage these patients. A quick note, the ATS guidelines now define progressive pulmonary fibrosis, or PPF, not just by radiographic or symptomatic worsening, but also about how your PFTs evolve over time or change over the course of a year. And so these will come handy later on down the road as you manage these patients too. So the next really key group of testing that you're going to get in your evaluation is a good quality, high resolution CT scan, and you're going to compare it to prior films as well too. And before you name what type of ILD you think you see on the CT, you're actually going to try to name the pattern first. So a good quality scan really is a non-res study that has thin, high-resolution sections measuring less than 2 millimeters. Inspiratory and expiratory images are mandatory. Prone images, according to the guidelines, are still considered optional, but they do come in very useful or come in very handy sometimes. The first thing that you're going to do when you get your CT scan is just name whether it's a UIP pattern or not. And this is really nicely highlighted in both the ATS and Fleischner criteria guidelines published in 2017 and 2018 on IPF. UIP pattern is simply defined, as many of you already know, by reticulations, traction bronchiectasis, minimal ground glass opacities, and a basal subpleural dominant fashion. And it can be with or without honeycombing. A non-UIP pattern, as you can tell from this slide, is the polar opposite of that. So you're going to see things like nodules, micronodules, cysts, lots of ground glass outside of regions of fibrosis, and it's in the wrong location. It's not basal, it's not subpleural. And then there's this funny group in the middle called indeterminate for UIP. And what that really means, in my humble opinion, is that neither you nor your favorite expert thoracic radiologist at your center really feel it has enough criteria to fit into a UIP bucket. At the same time, it doesn't have enough criteria to fit in a non-UIP bucket. It's just a very strange looking CT scan that you can't really pigeonhole into any category. If that happens to you, and I would actually argue for all of these groups, the next question to really ask yourself about your CT scan is whether or not you have a predominantly fibrotic pattern or not. So this is nicely highlighted in the most recent iteration of the HP guidelines that have asked us to pivot away from defining HP as fibrotic and, as acute or chronic, and more towards fibrotic or not. A typical non-fibrotic CT scan is really defined by ground glass opacities, central lobular nodules, mosaicism on those inspiratory images you obtained, and air trapping on expiratory images. Fibrotic HP is the exact same thing except features with fibrosis, many of which we just talked about in the last slide. And I think one of the reasons that the guidelines are really highlighting the importance of identifying these patterns is to make sure that we use them to narrow our differential. For example, we know that only about maybe half a dozen or so diseases are capable of causing a UIP pattern, out of which IPF, select cases of HP, and select cases of connective tissue disease are going to be your leading causes. There are other rare causes of UIP pattern like those written on the slide, but again, even in ILD, common things tend to happen more commonly. The other reason that these patterns will become important in a couple slides is they're going to help you decide if you need a cryo or surgical lung biopsy or whether you might be able to forego it as well too. And as we'll learn later on, I'm sure throughout the day, these patterns do predict prognosis to a certain degree, and so they're going to influence how you manage your patients to a certain degree as well. So the next really key thing to discuss is if you're anything like the rest of us, by the time your first hour with your new patient is over, you've kind of shotgunned the first 4 parts of this evaluation and talked to your patient for a lengthy amount of time and ordered a lot of testing. As the testing starts to come back in, all the guidelines really encourage us to pause here and take our case and present it in an MDD. And if your center doesn't have an ILD, MDD, or multidisciplinary discussion group, refer to a center in your area that does. And the reason is the MDD is going to change management in up to 30% of your cases. And more importantly, with respect to the biopsy, the MDD is going to help you decide if the biopsy is safe and if it's needed and what type might be right for that patient given their clinical presentation. So one of the first things that you'll probably debate in your MDDs is whether or not that biopsy is safe. The guidelines offer some guidance on this now, stating that cryobiopsy is an acceptable alternative to surgical lung biopsy. Part of the reason is cryo comes with less risk than surgical lung biopsy, but it also comes with a slightly less diagnostic yield as well too. In general, again, from a clinician standpoint, the patients that you probably don't want to offer cryo or surgical lung biopsy, in my opinion, are those that are older, those that are sicker, those that are hospitalized that you're considering a non-elective biopsy, and some of the other criteria listed on this slide as well, too. If in your MDDs you decide, no, this patient is safe to undergo a cryo or a surgical lung biopsy, then the next question you'll probably debate in your MDDs is whether or not the biopsy is actually needed. So here the guidelines also offer us a little bit of guidance, and they kind of teach us that at least when it comes to having a probable or typical UIP pattern on a CT scan, maybe a cryo or surgical lung biopsy isn't absolutely mandatory because over 70% of the time, your biopsy is going to show exactly what your CT showed, which is a UIP pattern. Similarly, if you have a patient with a classic history of HP and a typical non-fibrotic HP pattern on scan, perhaps you don't need to rush towards a cryosurgical lung biopsy. A simple bronch showing the presence of lymphocytosis might be enough to secure a moderate, if not high confidence diagnosis of HP. Similarly, connective tissue disease ILD patients don't really need a biopsy to diagnose them. They need a rheumatologist to help you diagnose them. And then in the vast majority of cases, as we all know, a simple bronch can diagnose most patients with sarcoidosis. So the patients that you actually want to consider cryosurgical lung biopsy are those that your data kind of doesn't point towards a leading diagnosis. You and your MDD are equally uncertain about what's going on, but everyone kind of agrees that it's safe to do the biopsy, it's needed. And most importantly, the patient understands that the biopsy is like every other test that we're going to talk about. By itself, it cannot diagnose the patient. Rather, it has to be integrated with that patient's history, exam, other data, clinical context to yield a moderate or high confidence diagnosis. If you choose to get the biopsy, all the guidelines really encourage us to present that data back in the ILD-MDD to try to arrive at some consensus. The other thing that you're going to do in that MDD is ask your pathologist the same questions that you asked your radiologist, which is, what's the quality of the biopsy and what's the pattern? This is especially true when you can't when your pathologist can't give you it's this ILD diagnosis. You're going to use the pattern to narrow your differentials as best as you can. There are times when you go through this whole beautiful algorithm and you spend hours with the patient and behind the scenes trying to diagnose them, and you take your data to your ILD-MDD and there is no consensus of what specific type of ILD that patient has. In that situation, you might wonder to yourself, was this a waste of time? And the short answer is no, because if you found a modifiable risk factor during any part of your history or exam, you're going to either eliminate that antigen exposure or modify that comorbidity. At the same time, there are times where there are no modifiable risk factors. If all you can say is, I have an unclassifiable ILD that's mostly fibrotic, it might influence how you manage that patient, as we all now know as well. For instance, in the olden days, pre-2019, select antifibrotics were really only allowed to be used for IPF, but now in the modern era, we know that there's phase 2 and phase 3 studies that have shown that antifibrotics can help benefit people even with unclassifiable fibrotic ILD. And so how you approach your initial evaluation is going to influence how you manage these patients. I'll end by saying that I hope I've convinced you that a thorough history exam and testing can really help narrow your differentials. When you get your CT scan, always make sure you ask yourself and your radiologist, what's the pattern? Debate whether a biopsy is really needed in your ILD-MDDs. And if you choose to get the biopsy, always ask your pathologist the same questions you asked your radiologist. And then I hope I've sprinkled this in throughout the talk, but if you forget everything I said, just remember you should not be making these diagnoses by yourself. Use your MDD or refer to a center that does. MDD truly is like a less scary version of ChatGPT, in my opinion. It really does help you integrate and interpret the data you collect, and it really tries to help you make a moderate, if not high confidence diagnosis of a specific ILD given that patient's presentation. Thank you so much, you guys.
So why am I standing in front of you while we wait for the slides to catch up? So as a rheumatologist, I have seen less connective tissue disease ILD in my rheumatology fellowship than I did in my first year of pulmonary fellowship. So it's out there. And why does it matter? Why is it important to find these patients with connective tissue disease? Because it changes outcomes. Unlike an idiopathic pulmonary fibrosis, where we know from the PANTHER trial that prednisone, azathioprine are harmful, patients with connective tissue disease ILD can stabilize or improve their lung function. And this is a massive difference from a lot of what you guys are going to be hearing about today. This is improving lung function. I've seen people come off of oxygen if they're recognized quickly and treated aggressively. For systemic sclerosis, this is a little figure from SLS2. mycophenolate, cyclophosphamide improve FVC. For myositis, this is retrospective data looking at azathioprine and mycophenolate, improves FVC over time over a cohort. And for rheumatoid arthritis, this is newer data showing that when you looked at FVC and you changed the patient from whatever they were on for RA to add lung-targeted immunosuppression, AZA, MMF, rituximab, the slope of the FVC decline flattened. So this matters. And the other thing I would implore everybody to realize is we always have this nihilistic view of UIP. In CTD, I don't care what their radiographic pattern is. They get better with immunosuppression. So this is going back to the RA study, 212 patients, multiple centers. 40% of those had UIP. And when they evaluated the lung trajectory after they were started on AZA, mycophenolate, rituximab, it stabilized in patients with UIP. Scleroderma, this was a very small study, but when they looked at mycophenolate versus placebo as expected, mycophenolate patients stabilized in blue and placebo continued to decline. And there was no difference in the median FVC change for NSIP versus UIP. Keep in mind here, a negative FVC is actually an improved FVC. It's an annoying convention. But they both got slightly better. For myositis, hopefully my slide will come here in a second, when you compared myositis UIP treated with immunosuppression to IPF, you moved your median survival from 2 years in IPF to 8 years with myositis and UIP pattern in transplant-free survival. So it matters that these patients have connective tissue disease, not that they have UIP pattern. And whether you want to be on the front line or not, you are. So this is internal data from our cohort where we found that a third of patients with myositis and just over a third with scleroderma presented to Vanderbilt first to pulmonary clinic, not to rheumatology. 40% in both groups had seen an outside rheumatologist. And this isn't to say that our community rheumatologists are bad, but these are hard diagnoses to make without your serologies. And there have been times in the ICU I would have missed it without a high pretest probability in serologies. And most of these patients are not referred for the correct diagnosis. So again, keep your eyes open. As one of my dear friends says, we want to be anti-racist and ageist. If you see a young person of color, they do not have IPF, they probably have a CTD, please have them see a rheumatologist before you do anything else. So how do I approach my clinic? Every Tuesday morning, I have usually 2, does this patient have CTD ILD? How do I approach these folks? Well, the first thing I want to realize and emphasize is that multiple rheumatic diseases can cause ILD. So we're having a naming change, which I know is super annoying for everybody, to systemic autoimmune rheumatic diseases, not just CTD ILD. And that's because RA and ANCA vasculitis aren't technically CTDs, but they still cause ILD. So we want to look for signs and symptoms of this. We want to obtain serologies because a non-trivial portion of these patients will present with lung involvement first. And most importantly, ACR guidelines are designed for research and not for diagnosis. Okay, so please, 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 my slide will advance, do not use ACR classification criteria to diagnose your patient. That's to get homogeneous research cohorts. It is not for diagnosis, and it will lead you astray. All right. So rheumatoid arthritis, statistically probably one of the most common rheumatic diseases. Significant portion of them have ILD. A lot of them actually don't progress. If you ask rheumatologists, they'll say that RA-ILD never progresses. If you ask pulmonologists, everyone dies if they're RA-ILD. It's selection bias. But RA-ILD has to be CCP positive. If it's not CCP positive, it's not RA-ILD. And that's because this is really a pathogenic antibody that started in the lung, being triggered by oftentimes smoking, citrullination. The other thing to realize is that uncontrolled joint disease will drive lung progression. So these patients need to be followed closely by their rheumatologist. We really need to treat them to target and get all that joint disease controlled. Next up, we're going to talk about myositis. Incredibly heterogeneous. Lots of different autoantibodies, lots of different forms. Horrible name. Lots of patients with myositis don't actually have weakness. So just because your patient's not weak doesn't mean they don't have this. The important thing to realize is that a lot of them will have subtle exam findings if we look carefully. I don't want to over-advance. And so these are some of the rashes that you can expect to see. We'll talk about MDA5 more in a second, but a significant chunk of these patients have lung-limited ILD, especially MDA5, especially non-JO antisynthetase. Disproportionately affects women and individuals of color, and to screen at these CK, aldolase, LDH, LDH can be involved with any lung inflammation, as we know, but it's still useful, and an extended myositis panel. I'm showing you over here on the right the subtle rashes that you can see. A lot of times what we were shown in med school are these raging rashes that you could never miss, but real life is more subtle, especially on skin of color. So Gottron's on Caucasian skin, we've taught to look for redness over the knuckles. In skin of color, this is going to be hyperpigmented, a little velvety appearing. It is not going to be that bright red angry. For heliotrope, reddish purple on Caucasian skin. For skin of color, have them close their eyes and actually shine the otoscope on their eyelid. It'll help that purple transluminate better, and it's easier to see. And mechanics hands, you're looking for cracking on the sides of the fingers. This side of your index finger is free. We all use that to grab things. I would like somebody to show me how they're using the inside of their ring finger to grab things and form calluses. So close your eyes, actually feel the sides of the fingers. You will be able to feel the roughness before you can see it, but if you're looking, your eyes will overrule your sense of touch. MDA5 is my most dreaded diagnosis. We have a policy at Vanderbilt to see all MDA5 positives within 7 to 10 days. You do not want to wait for your antibody to come back in the ICU for MDA5 positive. This is a clinical diagnosis whenever possible. There are lung-limited forms, but what we were looking for is palmar papules. So these are going to be almost like Osler's nodes, except at the little skin folds here. They're going to be painful. They're going to ulcerate. They typically have Raynaud's with those folks. The ulcerations, the top picture on the right is what we're all shown in the textbook, deep cratering ulcers over all of the knuckles, the elbows, the knees. Have I seen that? Absolutely. Please don't let it get to that point. What we want to catch it as is a little bit of Gottron's with that tiny little white dot in the middle where it's starting to ulcerate. That's where we want to catch and diagnose this. This is a very lethal form of myositis, up to 70% mortality at 1 year, sometimes within 90 days. And it's very interferon mediated. Mycophenolate may not work great for these folks. I tend to use calcineurins as first line. There is data for JAKi and rituximab as well. Systemic sclerosis. Again, you would think this would be a really obvious diagnosis. It's often not, especially in the masking world, because you can miss some of the subtle face findings. So 50% of patients with scleroderma will have ILD. This tends to be if it's progressive and early issue. This tends to not be the patient who has had skin changes and Raynaud's for 50 years and finally got a new PCP who heard something and they found ILD. This is the person who's having more changes now. Contrary to your teaching, just because you're centromere crest syndrome does not mean that you can't have ILD, and just because you have diffuse scleroderma doesn't mean you have to. So really realize any scleroderma patient can have ILD. They should all be ANA positive by immunofluorescence. They should all have Raynaud's phenomenon. Things to look at is this furrowing of the upper lip. That's a classic scleroderma feature. To look for decreased oral aperture, just ask your patient if they're having trouble eating their hamburgers in the last couple of years. Okay? If they can't unhinge their jaw anymore, their oral aperture is probably changing. Salt and pepper changes on the chest. Telangiectasia, super sensitive. You do not need 50 of them on your hands. You just need one. Okay? On Caucasian skin, these are going to be matte-like red telangiectasias. On skin of color, they're just hyperpigmented. Ankylosing, this is an uncommon cause of interstitial lung disease, but patients who have it have a worse prognosis, especially if they have UIP. If you have an ANCA positive, you need to screen for systemic vasculitis. A chunk of them will have it if you look. You need to get a CBC looking for anemia. This will be iron deficient. Slow DAH, the macrophages actually sequester the iron. It's not available for hematopoiesis, so this is an iron deficiency anemia. You want to get a creatinine urinalysis. First patient I ever saw with ankylosing had 75% crescents and a creatinine of 0.6. Okay, you do not need to have an abnormal creatinine to have glomerulonephritis. And remember, not all DAH patients will hemoptysize. All right, let me see how much time I've got. It's not running. Okay, well, we're going to move quickly because I think I talked too long there on the serologic approach to CTD-ILD. So our guidelines say that if we suspect a patient for having IPF, we should exclude CTDs with serologies, but the devil is always in the details. When they say an ANA needs to be done, we really need immunofluorescent ANA. where we're taking the patient's sera, putting it on a cell, usually a Hep2 cell, and then looking for immunofluorescence. In practicality, this is not what usually happens if you order an ANA. If you do not specify immunofluorescence, you will get a bead-based assay from usually Quest or LabCorp, where they take beads, they cover these beads in autoantigens, Rowe, Loss, Smith, RNP, SCL70, and then they see if the patient's sera detects the bead. So you've tested for your specific extractable nuclear antigens, but you actually haven't tested for an ANA. And so you can get a lot of false negatives there. So this needs to be an immunofluorescent ANA. There are ways to order that through commercial labs. You just have to distinguish it. ANA patterns matter. Not to belabor this, I don't care what titer a nucleolar or a centromere is. If it's there, we're done. If it's speckled or homogeneous, those are more common. Theoretically, things should map, but it never works as well as you would think it would. The other thing to realize, I don't want to go in the wrong order, is that ANA positivity occurs in a lot of diseases. Chronic infections, acute infections, cancer, older age, all of these things will increase your ANA positivity, usually with a speckled or homogeneous pattern. Again, centromere nucleolar, it needs to be taken very seriously. For RA, rheumatoid factor nonspecific. All it is an IgM, anti-IgG. It's seen in lots of other connective tissue diseases, but your CCPs are specific. That's what you're looking for RA. In terms of where rheumatoid factors are seen, there we go. It's going to be in most RA patients, but 75 to 95% of Sjogren's. In Sjogren's, you're looking for that Sicca syndrome. If you're not sure, if it's weird, if they're Rho negative, just send them to their dentist for a minor salivary gland biopsy. Trivial procedure, way safer than a lung biopsy. It's seen in a significant chunk of patients with myositis, again, lots of infections, and in healthy controls, especially in our older populations. Scleroderma, realize real briefly, your SCL70 and centromere will be tested for. Your RNA Pol3 will not unless you send it. If you see rapidly progressive skin disease, if you see really puffy fingers, send it, especially if there's a ton of ground glass. The reason this matters, RNA Pol3 is high risk for scleroderma renal crisis triggered by steroids. So you never want to give your scleroderma RNA Pol3 patient steroids for their ILD. You will cause yourself, in all likelihood, a new problem. So that can be added on separately. For myositis autoantibodies, you need to look at the phenotype. This testing is problematic. If you get a positive antibody for one of these ILDs that antibodies that did not cause ILD, major grain of salt. We've seen a lot of commercial SRPs with smoking-related lung disease, but I don't know why. For our synthetases, however, it's important to realize that the vast majority of these patients will have ILD, 70 to 100%. Your non-JOs are going to often be hypomyopathic, very few clinical symptoms. This is where your antibody can save you. If you have a young woman with an NSIP or UIP pattern who is EJ positive, it's probably antisynthetase syndrome, okay, even if you can't find much else clinically. Overlaps can do this too. Some people say these are scleroderma overlaps. They can do anything they want. All right, and this is commercial. Just realize they're different. We'll skip that for the sake of time. ANCAs, you need to order immunofluorescence and ELISA. These should match. So your C, I just always remember that your letters can't match. So P can't go with P, which means that your C ANCA has to go with your PR3 and your P ANCA has to go with your MPO. I could never remember it any other way other than your letters are not allowed to match. So what is my approach? History, history, history. History and physical, I use hospital gowns. I know we tend to not use them anymore, but it's really hard to see rashes if your patient is fully clothed from head to toe. And these are the commercial labs that I use with my transplant colleagues in the community when we're trying to get a remote serologic evaluation. And you can now get the Mayo Myomarker 3 through LabCorp. And so these are the tests that we send off in our folks. When to refer to room, if you're worried, why not? There's no risk to talking to one of us rheumatologists who do this all the time. And for that reason, our thoracic surgeons will actually send all these people to us before they do a surgical lung biopsy, and somebody who's young, of color, without a clear concern, or women lacking a family history of ILD. I would rather see 10 patients who don't need me than have one patient be missed. And with that, please give your patients with CTD immunosuppression, even if they have UIP. And this is hard, okay? Call a friend. Medicine's always more fun with our friends.
So it's picture time, right? So you can relax a little bit and everything. I don't have any disclosures. So we've seen this issue so far, right? There's a lot of diseases. A lot of them overlap. There's pathology that helps us out. There's HRCT that helps us out. But we're trying to boil this down to a singular diagnosis when we can, and that's really challenging. So you've heard already the importance of multidisciplinary discussion, and that really can't be overemphasized even as a guy who just looks at pictures in a dark room all day, right? That helps immensely to understand the clinical context of what's going on, and my differential changes based on that clinical context. So we want to set ourselves up for success. We've already heard, again, a little bit about the importance of HRCT. If you're not aware, the Pulmonary Fibrosis Foundation, a little plug for them, has guidelines on high-quality HRCT that's machine-specific, right? So if you're not an academic center that does a lot of this, then great, you probably don't have to think twice about this. But if you're not, and you're wondering, hey, are my radiologist colleagues keeping up with what they should be doing, you can look at this to see, hey, do we need to make some adjustments? If they haven't done it in 10 years, they probably need to make some adjustments, and that's not an uncommon thing to look at. Again, inspiratory effort, expiratory, and prones. And if, again, you don't do a lot of these, having the techs talk with the patients before they go and try to do an expiratory scan actually helps improve quality a lot. So, if we do a good scan, we avoid things like this, right? Is there pulmonary fibrosis here or not? Good luck, right? So, and you guys will probably see a lot of this type of thing. You know, hey, is there some abnormality here? I have to figure this out and such. Maybe there's some aerospace disease. Maybe there's some fibrosis. I'm not really sure. First pearl, if it's normal, call it normal. You don't have to overcall things. If you're squinting that hard to see something, it's probably not real, right? HRCT, by its definition, will be noisy, right? And it's easy to hallucinate things sometimes. That being said, you have to understand normal to actually be correct if you're going to call something normal. So is this scan normal? You see something going on here. I'm tricking you a little bit. If it goes to the next one, there we go. So if you look up earlier, higher in that scan, you see that this is actually an expiratory scan, right? Sometimes even when they're trying to do an inspiratory effort, they don't do that correctly. Repeated for this, and all of that went away, right? So that's just what a normal expiratory scan looks like, resolved completely on full inspiration there. There is some degree of air trapping that is normal in patients, right? Small little lobular areas of air trapping essentially can be ignored. Normal patients have those. It is not an indicator that they have a small airways disease that you need to be going and chasing down. Here's another example. Is this scan normal? Well, maybe in the dependent lungs you might see a little bit of ground glass abnormality. If you're screening somebody for ILD, you wouldn't want to miss a potential early case that might have something going on like this. Is this a little bit of ILA or ILD? So this is a good example of why prones help in those cases. Once you have established pulmonary fibrosis, established bronchiectasis, prones don't play a role, right? So once you know that they have that, there's no need to repeat prones after that point. But when you're screening early disease, or they don't have an established diagnosis, then this will help immensely eliminate that possibility for very mild disease. Osteophyte fibrosis is not true interstitial lung disease, right? So if it's occurring in those areas along the osteophytes, can I point? You guys can see. Oh, here we go. I hit the wrong button. There we go. You can see osteophytes here, fibrosis adjacent to that. When those occur together in that same area, that's not true disease. But if you have more disease than just that, then that's, yes, there's an osteophyte here, but that's too much abnormality to just be osteophyte-related fibrosis. So could some of this be accounted for by an osteophyte? Yes, but certainly not all of it. There's disease here. So another pitfall, misapplying common HRCT patterns, right? These patterns guide the differential diagnosis for these things. And most of diseases kind of fit into one primary category of, pattern, sometimes combinations of patterns in more complex cases, but it is a diffuse nodular lung disease pattern like you might see with sarcoid or HP and those types of things. Is it predominantly a mosaic attenuation type pattern, consolidation, bronchiectasis, et cetera. So we're going to focus on a couple of these today, the ones that have a little bit more difficulty sometimes. Mosaic attenuation. This refers to differential areas of attenuation, of density in the lungs on inspiratory effort, right? So this is on inspiratory. Is there ground glass abnormality or are there areas of hyperlucency, sometimes all three? There are multiple causes of this. It's not all small airways disease. So one of the things you can do is look at the margins of abnormality. Is it poorly or sharply marginated? If it's poorly marginated, it's more likely that ground glass abnormality accounts for the appearance of mosaic attenuation rather than it be an expiratory abnormality or a small airways disease. More sharply marginated, those hyperlucent areas. You can also look at the pulmonary vessels for distal attenuation, again, occurring more frequently in small airways disease or vascular disease. This was a case of ground glass opacity being the actual abnormality, kind of mimicking a mosaic attenuation type pattern here. Here's another example. Expiratory imaging helps you, right? Some cases you will only see expiratory air trapping on the actual expiratory films. The inspiratories will be pretty normal. You know, that can happen with HP, it can happen with other inhalational injuries. Here's an example. You can see mosaic attenuation on the inspiratory, and it's more pronounced on the expiratory, right? This is a case of constrictive bronchiolitis. You can also look at the airways for other airway abnormalities, the large airways for bronchial wall thickening, bronchiectasis, mucus plugging that might point you in that small airways direction as well. And remember, mosaic attenuation can and sometimes be related to chronic thromboembolic pulmonary hypertension or pulmonary hypertension in general. So you can see there's PE in the right lower lobe bronchus there. Sorry, I'm clearly hitting the button here accidentally sometimes, but anyway, bronchiectasis. There's two main imaging categories of bronchiectasis. There's bronchiectasis that's caused by an abnormality around the airways, pulling it, tethering it, traction bronchiectasis, and then bronchiectasis that's really predominantly due to a chronic airway inflammation. Those are really two different differential diagnoses from an imaging standpoint. One is a fibrotic pathway. I'm thinking about UIP and SIP, that type of pattern. And the rest is chronic airway inflammation, immunodeficiency. I'm thinking of chronic recurrent aspiration, chronic infection, ciliary dyskinesia, that type of thing. And again, it puts you down kind of two different pathways. You can look at the airways for abnormalities. If the airways themselves are more abnormal, bronchial wall thickening, mucus plugging, those types of things, think more along the ways of the chronic airway inflammation. If you're looking around those airways and you see a lot of reticulation and architectural distortion, think more on the traction bronchiectasis, fibrotic lung disease pathway. So fibrosis. If only every case was this easy, right? So clearly there's lower lung predominant reticulation. We've seen that pattern already. We've categorized that as a UIP pattern. It meets all those criteria for the ATS and the Fleishman Society guidelines. We've got honeycomb cyst formation. So what's the problem? Well, we got a lot of problems with this. One is just what is honeycombing? And it turns out that I don't agree with anybody else in this room, apparently, and nobody else agrees with anybody else about what constitutes honeycombing. We have the, yes, we all agree cases, but then we have a lot of cases that are in the middle, right? We all live on a day-to-day basis in this middle area here as far as is that honeycombing, yes or no? And our inter-observer variability there is really kind of at the lower limits of clinical acceptability, honestly. So recent guidelines with the change from a possible UIP pattern to a probable UIP pattern have somewhat diminished the necessity of being very accurate with honeycombing in some sense, but there's still prognostic information there. So some cases, we know, honeycomb cysts, right? Easy, well-defined. But don't confuse that with paraseptal emphysema. This is essentially like a pure paraseptal emphysema. There's no reticulation around these peripheral cysts. Pretty clear-cut. I think we can all tell the difference here. And then there's a pretty clear-cut case of significant bronchiectasis here as well. Nobody's confusing any of these. But there's other cases too, right? So here, I think we'd agree, most likely paraseptal emphysema. There's central lobular emphysema here too, but not enough reticulation or architectural distortion to point us in another direction, like this might be honeycomb cyst formation. Now, here, there's a lot of reticulation around those areas, This is honeycomb cyst formation. And let's try to guess this one. Paraseptal emphysema or honeycomb cyst formation? I think we'd all lean towards it being honeycomb cyst formation. Here's another one. Okay, now maybe we're a little bit less sure. I'd still think I'd lean towards honeycomb cyst formation here. There's kind of a single stacking layer, a little bit more reticulation around some of those areas. And then here's another one too. Now we're all in the less sure category, right? So this is, again, where we all live. There's going to be some observer variability between us. There are other cases like this where, okay, it looks like a clear-cut case of honeycomb cyst formation, and there probably is some honeycomb cyst formation here. But if you look at your coronals and sagittals, you'll see actually a substantial portion of this is really bronchiectasis and bronchiolectasis, tracing those all the way back down into the lung periphery. So there's probably less honeycomb cyst formation here than you might have thought. Priors are your friend, right? All priors are your friend, not just a prior HRCT, a prior chest imaging of any type, a prior CTA, a prior pulmonary embolism CT, with or without contrast, a prior abdominal CT. Sometimes a disturbingly large amount of your lung will be imaged in an abdominal CT, right? Consider that a freebie as far as looking at your priors. You can see cases like this where there's pretty profound fibrosis, and you go back and look at baseline, it might change your impression of how you got there, how this disease process is evolving over time. Look at all those priors. And then lastly, we're going to talk about gray lung, or essentially what happens when you've got fibrosis and then you have a ground glass abnormality or an airspace disease superimposed on that, right? It can be a chronic finding. It can actually be progressive fibrosis that's really beyond the resolution of CT to see it more as a reticular abnormality. But it can also be an acute finding as well, and we have to tweeze that out. If you have priors, again, very helpful, but you don't have that in all cases. So this is an example. IPF, it's not a classic pattern, certainly. 1 year later, more extensive ground glass abnormality, but the fibrosis has progressed as well. This is slowly progressive, and this ground glass abnormality really represents a progression of the fibrosis. Here's a case of acute exacerbation. Initial scan during hospitalization, 3 months later, where you have extensive ground glass abnormality superimposed on the baseline level of fibrosis, and then on follow-up, the fibrosis has progressed. More reticulation, more bronchiectasis. Here's gray lung and fibrosis again, a baseline level of fibrosis. More airspace disease superimposed. Do we think that's an acute exacerbation here? Well, it turned out that was pulmonary edema. Well, you might say that doesn't look like most cases of pulmonary edema, and you'd be right. But when you have underlying structural lung disease, fibrosis, emphysema, that type of thing, things look different, right? The lung doesn't react the same way that you would think on imaging. So this turned out to be a case of pulmonary edema. Here's another case where there's a baseline level of pulmonary fibrosis and airspace disease superimposed. Is this another case of pulmonary edema, acute exacerbation? Nope, that was an infection superimposed in that fibrosis. So you have to broaden your horizons from an imaging standpoint. Clinical context matters a lot for these things. Here's another one, gray lung and fibrosis, a baseline level of pulmonary fibrosis, and then more airspace disease, more ground glass abnormality superimposed on that. This is a case of acute exacerbation, right? So from an imaging standpoint, telling the difference between these things is very limited without clinical information to guide you in that right direction. One last one of these. Pulmonary fibrosis, lower lung predominant. This is just an example of expiratory CT, right? So if you got somebody in your ICU that you come up and you try to do a HRCT on them, it's generally a waste of time, right? They can't hold their breath long enough to do that very well. This is just an example of expiratory CT changing that. So remember, when you have ground glass superimposed on a baseline level of fibrosis, it can be a variety of things, and these features overlap greatly, more so than you would see in a patient who doesn't have underlying fibrosis or emphysema. And one last case, fibrosis, what looks like fibrosis, what looks like emphysema, or certainly some areas of cystic lucency. ground glass and consolidation superimposed. When things don't make sense, think outside the box. We thought this was organizing pneumonia superimposed on a baseline level of fibrosis, and it turns out this is all adenocarcinoma, right? So is that gettable just looking at this? No. Is it gettable the first time they show up in clinic? Probably not, right? So it takes time to figure out these types of things. And you might ask, okay, what portion of this is cancer? And the answer is all of it, right? Biopsy, autopsy proven in this case, right? So think outside the box sometimes with what some of these things can look like. So again, just leave you here, set ourselves up for success with a good HRCT. If it's normal, it's okay to call it normal, but it's ILD, it's tough. You'll hear again and again the importance of multidisciplinary discussion. It helps to have friends to knock things back and forth between. Thank you.
Good morning. All right, so I'm going to back clean up. And we're going to talk about something that we actually don't use perhaps as often as in the really olden days. I noticed that was before 2019, but actually maybe before I was in practice. I think there was a tendency to use the bronchoscope maybe a little bit more frequently than we turn to at this point. And that's because I think we've really firmed up some of our guidelines and diagnosis. We've really made some advances in imaging and our ability to interpret those. And so I actually wish I could show Dr. Sood's slide where it talks about, searching for a cause, still looking for a cause. Well, now we're down to I still am looking for a cause, right? And so we've been through all of these other pieces. All right, here are my disclosures. And I am going to remind you, as you have heard already this morning, that these tools that I'm going to talk about are really just tools, right? They are an additional piece of the puzzle that's going to help you diagnose this patient. But no bronchoscopic test, just like no other test, is going to be useful in a vacuum for ILD. You really need to go to the whole patient, to the multidisciplinary discussion that's always needed in making this diagnosis. And as my mentor, who I don't know if is in the audience today, Joao D'Andretti, used to tell me in clinic, it's not like cancer, but maybe sometimes it is, Dr. Hobbs. So. All right, so I'm just going to talk very quickly, one slide on bronchoalveolar lavage, and refer back to the 2018 guidelines from the American Thoracic Society. And there's a suggestion there that we could do a BAL for patients who are not suspected of having IPF with an HRCT pattern of UIP. So we probably shouldn't be using BAL in these patients, but we could do cellular analysis of our BAL in other populations. And there's some data from UT Southwestern in which bronchoscopy actually changed the diagnosis in just under a quarter of patients. Here on the left, I've shown that the BAL cell count actually may change your diagnosis more often in male patients, smokers, and when you have an HP antigen present, either in history or by testing. But it is unlikely to impact your diagnosis in those patients that have suspected or known CTD, or in a UIP pattern on high-resolution CT, those patients who you're very suspicious have APF. Oh, wow, that's a sensitive button, although it is pretty slow. So I'm going to talk for a few minutes about transbronchial cryobiopsies, and I'm going to disclose to you, I didn't say this in my disclosures, that my center actually doesn't do cryobiopsies. So I am talking to you from book learning, as we say in Georgia. But there is an increasing amount of experience and published literature on transbronchial cryobiopsy. And there's been some updates to our guidelines on the basis of this emerging literature from some of the higher volume centers. And I'm also, another disclosure, not a pathologist. So I show this image here to show the difference in size. So if we start at, I have a thing here. Oh, I just went backwards. Oh, crumbs. Okay. I'm not going to touch that again. If you look at the left of the slide there, that is sort of your more traditional transbronchial forceps biopsy. In the middle, those are transbronchial cryobiopsy specimens. And to the right are surgical lung biopsy specimens. And so you can see kind of the relative size of those, the forceps biopsies being 0.1 to 0.3 centimeters usually, cryos getting around half a centimeter, sometimes bigger, and surgical lung biopsies usually, a few centimeters. How did that happen? I didn't even touch it that time. Now, there was an update, as I mentioned, in the ATS guidelines, and in 2018, the Guidelines Committee declined to make any recommendations on transbronchial cryobiopsies, just feeling like there wasn't good agreement on that or enough data to make a recommendation. But with additional data, and actually a published review of the literature that came out at the same time as the new guidelines, the 2022 update suggests that transbronchial cryobiopsy could be a reasonable alternative to surgical lung biopsy if there is experience in the procedure and the interpretation of the results at the center. I didn't really touch it. Oh, how'd that happen? Somebody's doing something there. Okay. So I created this table from several recent reviews. And in general, I'm not going to read this to you, but in general, the diagnostic yield increases with the size of the biopsy. So if you have transbronchial forceps biopsies, they tend to be smaller, cryos are a little bit bigger, and your surgical lung biopsies are substantially bigger than that. Now, the diagnostic yield for UIP or NILD significantly lower for transbronchial forceps biopsies, but as you get those bigger specimens, the diagnostic yield goes up. And the trade-off between cryobiopsies and surgical lung biopsies is a small decrease in that diagnostic yield, but it's getting pretty close in those experienced centers. Conversely, complication rates tend to go up with the size of the biopsy, and the risk of complications such as acute exacerbations and things like that, particularly in our higher risk patients, goes up as you get into the larger and then surgical lung biopsies. Mortality can go up particularly in non-elective surgical lung biopsies. All right. You know what's happening.
Is it skipping a slide?
No, I think it's okay. The biggest difference in our flowchart, so this is an updated version from our ATS updated guidelines, and the biggest difference here really is that there's a move of the probable UIP high-resolution CT pattern over to perhaps not considering or needing any biopsy BAL or surgical lung biopsy. Now, we obviously still need a multidisciplinary discussion. We're not gonna forego that, but we can oftentimes, in the correct clinical situation, make a diagnosis in that high-resolution CT pattern or in those patterns without additional tissue obtained. And then also the inclusion of TLBC or transbronchial lung cryobiopsy in that algorithm there as an alternative to surgical lung biopsy. And then the European, now it's doing the delay. Now, the European Respiratory Society guidelines were also updated, and this included, okay, there we go. This included cryobiopsies in their 2022 recommendations as an alternative to surgical lung biopsy, and that is because what they saw in the data was lower complications, lower cost for that biopsy, and as an alternative for those patients who were suitable candidates for the bronchoscopy and cryobiopsy, but perhaps too sick to have a surgical lung biopsy and get through that. Okay. So I am going to bring forward just one study. There are some great reviews out there of the literature, but this is a cold ice study, and it is probably worth knowing for boards, although I do not rate board questions. That's another disclaimer. May or may not help you here. This is a multi-center Australian study that compared in the diagnosis of ILD, cryobiopsies and surgical lung biopsies. This was done prospectively, and they looked at the concordance with pathology diagnosis. They looked at the concordance after multidisciplinary discussion, and they found actually that the concordance for the histologic diagnosis was actually quite high in the 70% range, and up to 77% for after multidisciplinary discussion concordance, and even higher when there was high confidence after the multidisciplinary discussion. And in this study, they really didn't see any major life-threatening bleeding with the transbronchial cryobiopsies, and a low and less than 10% pneumothorax rate, which is one of the other things that people worry about, and a low rate of acute exacerbation, subsequent mortality. So in addition to that, we also have some guidelines from the ACCP that were published in 2020, and this is for the use of cryo specifically to diagnose interstitial lung disease. So they had 6 points for implementing transbronchial cryobiopsy for that diagnosis. They felt like it can be used to provide adequate histopathology for a multidisciplinary discussion, let me say that one more time, in interstitial lung disease. They recommended doing those cryobiopsies in at least 2 sites to improve the yield. So risk of complications goes up the more sites that you do, but the risk of low yield goes up the fewer sites you do, so they felt like 2 sites was reasonable to improve the yield. They recommended, and this is technical, putting the tip of the cryoprobe 1 centimeter from the pleura to adequately sample in that area. And they also recommended using fluoroscopy to help achieve that. And then, there is some concern about the risk of bleeding when you take these larger biopsies. And they recommended the use of a bronchial blocker with an endotracheal tube or a rigid bronchoscope could help to control that bleeding without having to, remove the scope and go back in and try to control bleeding after that. And finally, they recommended using a smaller cryoprobe rather than the larger version of that, and that was for safety, but also adequate yield with the smaller. All right, and then I'm just going to talk briefly also about genomic classifier testing. So the genomic classifier that is commercially available is first used clinically in 2016, studied obviously before that. And this is performed with pooled transbronchial biopsy, forceps biopsy, most often specimens that are obtained at bronchoscopy procedure. Uses some, and I'm going to do some hand waving with this, whole genome RNA sequencing, and that creates a molecular signal. And without going into the details of how this, these machine learning to try and figure out what this signal looked like and adjust the sensitivity and specificity, but that was correlated with UIP on histopathology. And so all said, a positive genomic classifier predicts histopathologic UIP by surgical lung biopsy in this case with a sensitivity of 88% and specificity of 70%. So we're going to refer to that as genomic UIP. A negative classifier, notice our sensitivity and specificity, does not necessarily rule out UIP and doesn't actually help you if there is an alternative pattern present, doesn't tell you what that pattern would be. So it's a positive or negative test, and you really have to put that in the context of your pretest probability, and we'll talk about that in a minute. Subsequent studies have actually been done, some of them on the original data sets that were used to develop the genomic classifier, and then some on in observed data later that have shown that this genomic classifier, when provided to physicians and in multidisciplinary discussion, can increase the diagnostic confidence and be used as a complementary tool, obviously with HRCT. We're not going to use that in a vacuum, and has a 76% correlation with transbronchial cryobiopsies. All right, so Now, can we use this prognostically? I actually think this is a really interesting way to take this information. Seems like the jury's probably still out on this, but there is an interesting study that was published earlier this year. It was retrospectively done, 7 sites, and they used the genomic classifier result and then looked at the diagnosis, the HRCT pattern, and then for markers of progression subsequently in those cohorts, including death, transplant, and a FVC decline of 10% or more. Now, in this study, the positive genomic classifier, so indicating genomic UIP, was pretty highly correlated with probable UIP on the HRCT. And I should take a step back and say that these were retrospective, so all of these were collected and done prior to the update in the ATS guidelines that moved probable UIP on HRCT over to potentially not needing additional information and making a diagnosis of IPF without a biopsy, BAL, or any other thing. So many of the patients in this study actually did have probable UIP who may not at this point be subject to any additional diagnostic evaluation, but that was prior to the change. So that finding on the genomic classifier is highly correlated with a probable UIP pattern in HRCT. But when they looked at markers of progression, the genomic classifier result, positive or negative, wasn't really correlated in the large population with progression-free survival or FVC progression. So I think there probably is more information to be obtained, some more study to be done on perhaps the indeterminate UIP population to understand, how much was the probable UIP really weighing into that and not allowing us to see perhaps some utility there. So the Clinical Practice Guidelines Committee of the ATS, when they made their updates in 2022, actually didn't really agree on changing the recommendation. So they chose not to make a recommendation on genomic classifier use in those updates. And that's for a couple of reasons. They felt like the evidence was not yet sufficient regarding the testing characteristics and fitting into that algorithm. It was a little unclear to them, I think, probably, and I'm reading between the lines here, but with the move of probable UIP, how much added benefit we would get to those existing diagnostic evaluations. What are the implications of a false negative test? And then lack of clarity at this point whether genomic UIP determines that this is IPF, or is this more correlated with histopathologic UIP of any cause? And so there's no formal recommendation, but there's probably a place for this in our practice. But we really have to think about what we're going to do with that information, what our pretest probability for IPF or histopathologic UIP is before we go into that, given the sensitivity and specificity. All right, so just to wrap up, the BAL may actually impact our diagnosis in certain patient populations. It's pretty narrow, but particularly when we predict that HP is a problem. Transbronchial and cryobiopsy in experienced centers can be used as an alternative to surgical lung biopsy. And then genomic classifier testing, particularly in indeterminate UIP HRCT patterns, can be useful. And there are probably some future areas of research needed to decide the prognostic value of that particular test. All right, thanks.
Hi, everyone. My name is Anna Gersten. It's such a pleasure to get to be here and speak with you all today. You'll hear from many of my colleagues about management of specific types of interstitial lung disease. What I wanted to start off is sharing a little bit of general guidance for how we can practice symptom management along the way, regardless of the different treatments or illness trajectories of our patients. I have no conflicts of interest or disclosures for you. So I wanted to start by talking about how our patients with ILD feel. And I really like this cogwheel analogy because I think what it shows is that all of these symptoms work together to impact and usually hinder quality of life. And in order for us to really treat one of these symptoms, we actually should assess for and treat all of them so that we can be sure to do what we can to optimize quality of life. So I wish I could speak to you about every single symptom and management and assessment, but today we will talk about the three main symptoms that our patients with ILD might experience. So these three main symptoms are dyspnea, cough, and fatigue. So we'll start by talking about dyspnea. So I really like this 5-step approach to assessment and then management of dyspnea. And so we always want to start by assessing the symptom burden, and we'll talk through some more details on how to do that in the next slide. We want to try to formulate a differential diagnosis about what might be contributing to this patient's symptom of breathlessness. We want to work with the patient and their caregivers to create an intervention plan. We want to implement said intervention plan, and then we really want to monitor for the impact of our intervention and then continually review if we need to tweak or modify what our intervention plan is. And I like the big arrow at the bottom because, even though we go through steps 1 through 5, we constantly need to return to step 1 and make sure that we're really assessing how the patient's doing and how we are doing with their symptom management. So I wanted to start with sharing some common tools that you all might be familiar with. Oftentimes we use patient-reported outcomes. So I think most everyone in the audience is familiar with the MMRC. Importantly, that is a tool that's validated in our patient population. Certainly the VAS for dyspnea can be very easy for patients to complete and is once again validated in our patient population. The numeric rating scale is oftentimes used and can easily be implemented in other patient-reported outcomes. The dyspnea 12 scale is often used, the UCSD shortness of breath scale, the modified Borg scale, which I think we use very frequently, but is important to note. It's actually never been validated in our particular patient population. And then for our patients that might be nonverbal, especially towards the end of life, the RDOS is a wonderful scale for really evaluating how breathless that patient might be. So when we think about a differential diagnosis for why our patients might be dyspneic, now certainly the patients that we'll see have underlying interstitial lung disease, but it doesn't mean that there are not additional contributing factors to their breathlessness. And so I really like this mnemonic breathe air. I use it just to make sure that I'm being as comprehensive as possible in my kind of assessment of the patient themselves. And so B stands for bronchospasm. So certainly we would want to treat this with bronchodilators. Sometimes ipratropium or inhaled corticosteroids can be helpful. Sometimes systemic steroids can be helpful. R stands for rails. As everyone here knows, that's very non-specific. However, we can kind of be thoughtful about whether we think this might be from volume overload and whether the patient would benefit from diuresis, or whether we think there might be a bacterial process for which the patient would benefit from antibiotics. E is for effusions. Some of our patients with CTD-ILD might have effusions from their underlying autoimmune condition. We always want to start by draining that effusion and then asking the patient if they've had symptomatic relief from that intervention. Sometimes we think about an indwelling chest tube or pleurodesis. A stands for airway obstruction or aspiration. So the first step in our patients, in particular if they have a tracheostomy, would be to make sure we suction the airway, make sure there's no occlusion there. And then if we are worried about aspiration, to work with a speech and language pathologist to try to help the patient and their family to make dietary modifications that can help decrease the risk of aspiration. For patients that may have some underlying bronchiectasis and thick secretions, working very hard on airway clearance, which we'll talk about in a future slide. In patients who have a low hemoglobin, and this is usually in the 6 to 7 range, transfusion of packed red blood cells can be helpful. Some of our patients will have underlying arrhythmias that will actually contribute to their symptoms of dyspnea, and making sure that they're on appropriate antiarrhythmic therapy can really help with this symptom. Anxiety is intimately tied with dyspnea, so certainly teaching our patients relaxation tools, breathing strategies, but there certainly is a time and a place where having medications like a benzodiazepine to be given PRN can actually really help our patients with their dyspnea. Interpersonal issues can contribute substantially, especially to sudden onset dyspnea, and so we want to make sure that we are appropriately evaluating for someone's kind of psychosocial situation and getting them set up with counseling, certainly with the involvement of social work if we have that available. This is something that I've learned actually more through my palliative care training, is that oftentimes in our patient population, religious concerns can actually manifest with worsening of dyspnea. And so this is something that many providers trained in pulmonology aren't quite sure how to manage. And so I think, consultation with a spiritual advisor for the patient, their family, or working with a chaplain can be very helpful to help manage this aspect of someone's overall dyspnea. So I just wanted to make sure I put a plug in for the critical role of supplemental oxygen, in particular for managing dyspnea for our patients. So I would certainly encourage all of you to assess for oxygen needs with formal walk testing frequently, just to make sure if their oxygen needs change, that we're helping the patient and family to know that and facilitate getting the appropriate amount of supplemental oxygen. I always inquire about actual use, in particular with patients that are on higher liter flows. Sometimes it's harder for them to get this, and so practically they're not actually doing it. And then troubleshooting oxygen issues or discomfort is really critical to making sure that we're able to manage the patient's dyspnea through use of supplemental oxygen. So just to review briefly the non-pharmacologic approaches to dyspnea, number 1, 2, and 3 should always be pulmonary rehab. This is the one intervention that we have so much data to know that it works and it helps. Breathing techniques can be taught during pulmonary rehab, or there are some beautiful websites with really nice tools for patients and their families to review and learn breathing techniques. A fan can be extremely effective, or just opening up a window and making sure there's a flow of cool air to the patient. Stress reduction in general. Acupuncture in and of itself, actually there's some data to show that it can help improve symptoms of breathlessness. And then supplemental nutrition is actually key here, and a lot of this is protein, making sure that the muscles are built up as much as possible so that that patient is able to breathe in an as effective manner as possible. When we move towards pharmacologic approaches to dyspnea, certainly the mainstay and the most effective therapy in general is opioids. I usually start very, very low. We try to do the lowest effective dose and then kind of slowly increase as needed. Certainly, there is a role at times for extended release opioid formulations to help with that baseline level of dyspnea. And then we certainly can add on PRN opioids as well for episodes of acute breathlessness. Benzodiazepines are helpful in patients who really have severe anxiety that may be triggering or contributing substantially to the sensation of dyspnea. I will say that there's a nice synergistic effect between opioids and benzodiazepines. So in particular, when we're moving more towards the end of life, this combination of medications can be extremely effective. Corticosteroids, when there's an element of inflammation or obstruction that we think may be contributing to the sensation of dyspnea. And then in patients that have chronic secretions, making sure that we're really staying on top of secretion management so that that sensation of feeling those secretions in the airway is not triggering dyspnea. So just to take a pause, I've had a lot of my patients and their families tell me, okay, so we have this global plan in place, but what do I do practically? And so I think having actual breathlessness action plans, which I actually print out on a sheet of paper and fill out with the patient and their family. We put a copy up on their fridge, and then I like them to keep one with them to make sure that in acute periods of crisis, they have something concrete that they can open up, look at, and try to utilize. So this is just one mnemonic for a breathlessness action plan. It's not the only one, but I like it because it's called COMFORT. So C is call and calm. So this is making sure that if the patient is not with a caregiver, that there's a clear communication system in place if that patient needs help, how to reach out to their caregiver. Observe an oximeter, so making sure that if the caregiver may be with the patient, that they're just taking a step back, they're watching the patient's respiratory status. Certainly, if the patient might have increasing hypoxia, we're catching that on pulse oximetry and then increasing the oxygen flow accordingly. Medication, so once again, I think there is a time and a place where in certain patients, there is a role for PRN medications, usually either opioids or benzodiazepines. Certainly having a pocket fan can be wonderful. Supplemental oxygen, as we've talked about. There's also a role for non-invasive ventilation, even in our patient population, to be utilized really as a symptom management tool. And then reassure and relaxation. I think this is helpful for both the patient and the caregiver, especially if they're truly in respiratory distress, just to have a prayer or a mantra that both the caregiver and the patient might be able to say, some breathing techniques that the patient can utilize, guided imagery. And then this is what I think is actually most critical for the patient, especially in times of true crisis and respiratory distress, is just reminding the patient that it's okay to take their time. They don't have to talk right away. They don't have to explain what's going on. We're going to just go through our action plan and work on getting them to feel better, and then we'll get them the care that they need. So moving on, the next symptom that we'll talk about today is cough. And so there are less tools in general for us to use to assess cough. So the Leicester Cough Questionnaire or the CQ-LQ are the patient-reported outcome measures most frequently used. I think it's very important in our patient population. We always want to evaluate for common causes of cough. So use of ACE inhibitors, concurrent gastroesophageal reflux disease, seasonal allergies, and then any other possible reversible etiologies contributing to the symptom of cough. And so starting with non-pharmacologic approaches to cough, so making sure that if they have excess secretions, that we do chest PT for patients who might have some element of neuromuscular weakness and an ineffective cough, getting them set up with cough assist devices, working with speech and language pathology. Actually, hot tea can be extremely effective, and then oral lozenges can be extremely effective for our patient population. When we have a cough that we know is associated with mucus production, once again, most often in our patient population in the setting of bronchiectasis, would be airway clearance. And the way that I usually help guide patients and their caregivers through airway clearance would be starting with pre-treatment with a bronchodilator like albuterol, followed by nebulized acetylcysteine, which just helps us break up some of the secretions, hypertonic saline can be extremely helpful just to promote expectoration, can certainly be very uncomfortable while the patient is actually utilizing first a nebulized solution and then expectorating. And then, there may be a situation in which a short trial of antibiotics may actually help profoundly with the symptom of a productive cough. So other kind of first-line approaches to cough from a pharmacologic perspective, so opioids are central cough suppressants. They work extremely well. When we try to stay away from the full side effect profile of opioids, oftentimes we try dextromethorphan, which can also be quite effective. Tessalon pearls may work in a subset of patients. I am a huge fan of gabapentin. It's extremely effective for more of a neurogenic component to cough. And then corticosteroids, once again, are extremely helpful when there's an element of inflammation or concurrent obstruction. Second-line pharmacologic approaches, so these are approaches that we actually don't have very good data, but we can kind of intellectually understand how they would be helpful in treatment of cough. So baclofen, carbamazepine, and amitriptyline. The next 3 agents are actually in clinical trials right now. Most of them are phase 2, but there's some data that suggests maybe it would be helpful. This is more in a general patient population with advanced lung disease, not necessarily for our patients with pulmonary fibrosis. So moving now to the last symptom that we'll discuss today is fatigue. So the way that we assess fatigue, there are 3 kind of patient-reported outcome tools that we can use. There's the brief fatigue inventory scale, there's the numeric rating scale. Once again, the visual analog scale can just be extremely helpful for patients to identify how symptomatic they are. What I think is extremely important is always for us to inquire about our patients' sleep patterns and quality. Many of our patients have concurrent obstructive sleep apnea that, when treated, can help substantially with their symptoms of fatigue. So really the key here is going to be non-pharmacologic approaches to treating fatigue. So exercise is number 1. We have the best data to support exercise. Once again, pulmonary rehab is wonderful. Nutrition in general, helping our patients to try to get in fruits, veggies, protein, trying to make sure that their overall body is as healthy as possible and they're not having a lot of vitamin or mineral or other nutritional deficiencies that are contributing to the sensation of fatigue. And then cognitive behavioral therapy and reframing a bit the way that the patient is experiencing the symptom of fatigue, in particular with our patient population, can be extremely effective. When we think about pharmacologic approaches, these are not long-term approaches, these are short-term when we need them. So certainly doing low-dose corticosteroids, methylphenidate, and modafinil. In general, we only use these more towards the end of life, or if there's really an acute crisis for the patient that we're trying to get them out of and we're trying to get them more physically active. And this is my wonderful team led by Sonia Danoff. Thank you all so much, and please feel free to email me or reach out to me at any time if you have any questions or concerns.
Just figuring out how to use the slides. Thank you so much for having me. It's an honor to be here and speak to you today. So today this are my disclosures. So today I'm going to take you through thinking about the prescription of antifibrotics, in particular very important in our patients who have pulmonary fibrosis. And so through this overview, we're going to talk first just about what are the antifibrotics and what do they do, what is their role, what is the data. And then we'll think about specifically, when do we think about starting these medications on our patients? And I'll talk specifically about idiopathic pulmonary fibrosis. And then I'll talk about some of the other etiologies of pulmonary fibrosis that we may consider antifibrotics for these patients. And then lastly, we'll talk a little bit about managing side effects and also, very importantly, managing expectations for our patients with these medications. So not to get into too much of the science here, but just to think about what are these medications doing, right? So we have 2 antifibrotics that are approved by the FDA for idiopathic pulmonary fibrosis. And so when we think about how these medications work, essentially they work on the profibrotic pathways in the lung, and it's obviously very complex. And so you can see here pirfenidone has potentially several mechanisms working on that very sneaky TGF-beta that we think about, right? And so there's several pathways that we think pirfenidone may work on to attenuate fibrosis in the lungs. Very similarly, nintedanib also works on different profibrotic pathways in the lungs, and so you can see that here from this cascade, and there's several sort of downstream cascades that lead to fibrosis. And so that's when we conceptualize what these medications are doing, there's potentially several pathways that we would consider. And so first we're going to talk a little bit about IPF, because that's where our initial data came from for both of these medications. And so this is from the recent guidelines for the diagnosis of idiopathic pulmonary fibrosis. So we can all sort of think about, we have a patient in our office, right? They come in with a new diagnosis of pulmonary fibrosis, and we're going to first go through and obviously figure out what the etiology is. I know we've gone over that already this morning in the diagnostic talk. So you have a patient that's suspected of having idiopathic pulmonary fibrosis. They have a UIP or probable UIP pattern on their CAT scan, and then you basically are done, right? You're in your MDD, you're gonna talk about that patient. If there's no other potential etiologies, and it's pretty convincing for IPF, you're gonna give that patient a diagnosis of IPF. So then what do? What's the next step? So there's 2 medication options, like I've already alluded to. So pirfenidone, in the studies that have looked at pirfenidone, published back in the sort of early 2010s or 2014, pirfenidone reduces the rate of decline in FVC, right? That was the primary endpoint in the studies of pirfenidone. And you can see here in patients that were included in these studies with mild to moderate IPF based on lung function, the change in FVC over time was reduced. The decline in FVC was reduced in patients who were in the pirfenidone arm compared to placebo. There's also data in these trials to suggest that pirfenidone can also reduce the risk of respiratory-related hospitalizations in IPF, and you can see that here from the pooled data from the trials. And so not so much all-cause hospitalization, but when they looked at respiratory-related hospitalizations, we saw that there was a trend to improve the risk of respiratory-related hospitalizations in patients who were given pirfenidone in the studies. Similarly, in the studies of nintedanib, the 2 Impulsis trials, we found that nintedanib also reduced the rate of decline in FVC over time in the study in people who were in the study drug arm compared to placebo. And you can see that very clearly here. Over the 52-week study, the people that were in the nintedanib arm had less of a decline in lung function than the people who were in the placebo arm. And similarly, in looking at the Impulsis 2 study, there was some data to suggest that nintedanib may decrease the incidence of acute exacerbations in IPF. You can see that here. So we know what these drugs do in IPF, and I just showed you that data. And so when we have our patient that we just talked about, when we went through the diagnostic process, the next step is to consider, how should I treat this patient? And so there's been some, I think, controversy. Maybe some of us have heard some of these pro-con debates over time in the past decade or so about when we think about starting patients on antifibrotics. And the way that I like to conceptualize it is for every patient, we should go through the exercise of considering starting these medications at first diagnosis. And why is that? Well, we should consider the facts. IPF has a poor prognosis. IPF, the behavioral is unpredictable, right? Patients are at risk for acute exacerbations. We know that lung function will decline. We know that lung function will decline over time. And we also know that lung function decline is strongly tied with mortality. These are things that we know. These are facts. But we also have to consider the individual patient, of course. And so we have to think about the side effect profile, which we'll talk a little bit about. We have to think about patients' other comorbidities and other medications that they might be taking. And we also have to think about other life-limiting illnesses that a patient might have and a patient's preference, right? A patient's preferences and goals. What are our patient's goals and preferences in their treatment plan? And so really it comes to shared decision making. We have our facts and then we have each individual patient, and that's how we come to our conclusion about when to start antifibrotics. And so what about the watch and wait approach specifically in IPF? I think this comes up a lot. And so what do we know? So this is looking at the placebo arm in the pirfenidone trials, and what they looked at is to see what happened to those patients over time, right? When we looked at where they were starting off when their lung function and over time. And what we found was that the starting FVC, so if someone has a mild restriction or normal lung function, it doesn't predict what will happen or the decline. Similarly, starting gap stage, right, or prognostic stage also does not predict a lung function decline. So even though your patient coming to you may feel relatively well and have relatively preserved lung function, that does not predict what will happen over time. And so for these patients, we would really consider starting on everybody. And then I think in most of our patients, I usually have the conversation about, these are the side effects, which we'll talk a little bit about, and then also, what are their preferences? And I think we just have to be really honest with our patients and talking about this is the risk over time and how the lung function is going to decline and the mortality risk with IPF. And then we'll discuss with our patients together on what the right decision is for the antifibrotic. So we also know that a percentage of ILDs that are non-IPF, so now moving on from IPF, will develop pulmonary fibrosis. And so you can see that here. This is also from the new guidelines for pulmonary fibrosis, that all other ILDs, there is some percentage of them that are at risk of development of pulmonary fibrosis. And you can see that here. And so what is progressive pulmonary fibrosis? We have new guidelines that I'm sure we'll hear about at this meeting. And so it happens in a patient who has ILD of a known or unknown etiology, who has radiographic evidence of pulmonary fibrosis and at least 2 of the following 3 things, which we'll go over with no alternative explanation. So worsening respiratory symptoms. We heard a lot about dyspnea, cough, and other worsening respiratory symptoms that can happen in our patients. Physiologic evidence of disease progression. So what does that mean? We think about lung function. So decline in FVC greater than 5% over 1 year, or a decline in DLCO greater than 10% within a year. And then thirdly would be radiologic or radiographic evidence of disease progression. So 2 out of these 3 things would put somebody into that category of progressive pulmonary fibrosis. And so there have been studies looking at antifibrotics and progressive pulmonary fibrosis in people who do not have idiopathic pulmonary fibrosis, but other etiologies of ILD. And in particular, I'm sure everyone is familiar with the study of nintedanib, where we found that nintedanib, similarly in patients who have pulmonary fibrosis from other etiologies, reduces decline in FVC compared to patients who are on placebo in that trial. Similarly, when we talk about connective tissue disease ILD, systemic sclerosis-related ILD, which probably has the most research that's been performed in any connective tissue disease ILD, we've also looked at nintedanib in that patient population as well. And similarly found that there was a reduction in decline of FVC over time in that population. Now, the thing to keep in mind with this study was that half of those patients were on mycophenolate during the trial, right? And so some of the thinking is that over time, in people that were on mycophenolate, which we know we've studied in the SLS trials in systemic sclerosis ILD, is of benefit to patients, isn't already FDA approved for that. And so the thinking is was there some benefit, right, to those patients? And so right now, there's really not in the guidelines, and we have new guidelines for that as well that was just published recently, sort of where the role of an antifibrotic takes place. When do we consider adding it? And I think it really is for every individual patient. And oftentimes I'll work very closely with our rheumatologists to help determine how active is their connective tissue disease, right? Do they need more immune suppression for that reason? And so sometimes we have to really think about, of course, the whole patient and not just the lung disease, especially in cases of connective tissue disease, ILD, where they may need more immune suppression. And so I really like this graphic, and I feel like we could go through each of these ILDs individually, and I think we're going to have talks on that. So when we're just thinking about the antifibrotics in general, so we start off with all of the non-IPF ILDs, right? And we saw that schematic before, where you could see that there's a certain percentage that we expect will develop progressive pulmonary fibrosis. And so we've decided on our treatments, and we could go through these algorithms, I think, individually at some other time. And if the disease progresses despite these therapies, that's when we start to think about an antifibrotic in our patients. And it's not one size fits all, right? It's going to be individual. For example, if you have a patient who has a very aggressive myositis, who has progressive disease, you may think about increasing immune suppression more before you're going to add an antifibrotic. And so it's really individualized, and we don't have great guidelines yet for some of this. And so I really just like to go through this exercise in my mind of, especially for these non-IPF ILDs, are other treatments potentially beneficial in this individual patient before I consider an antifibrotic, or is this the time to consider an antifibrotic now? All right, so now talking about adverse events. So we've talked a little about when we consider starting these medications, what the criteria is for FDA approval and for insurance to cover these medicines, which I didn't even go over, but of course we all have to think about that as well in our patients' insurance coverage and copays. But the other thing that is really important to address with our patients up front is the expectation for side effects. We know for both antifibrotics, gastrointestinal side effects tend to be the most common. I think we've all experienced that in caring for our patients with pulmonary fibrosis. And so with pirfenidone, this is a really nice review that was written where they went through all of the studies and looked at the percentage of side effects in each of the major studies of pirfenidone. And so you can see gastrointestinal side effects such as nausea are very common, dyspepsia, anorexia. We see that a lot with our patients. Rash or photosensitivity rash specifically is seen in a number of our patients. And other things such as fatigue we've seen, and we've learned a little bit about fatigue, but we also have to think about side effects of the medications we're giving our patients, right? And so some of this antifibrotic in particular can be associated with fatigue. And then what about nintedanib? So I think the number 1, 2, 3, 4, 5 thing we think about in nintedanib is diarrhea, right? I think that's a real thing that we have to always talk about with our patients because in the studies, it was a very large percentage of patients that developed some level of diarrhea. Now, not everybody is going to have severe diarrhea, and of course, we need to talk to our patients about it's likely that there may be some, but it may not be very severe and it may be manageable. And again, that's sort of the risk-benefit discussion that we have to have with all of our patients when we're thinking about the benefits of this drug related to the side effects. Other gastrointestinal side effects such as nausea, vomiting, reduced appetite, weight loss, we see these in patients who are placed on this medication. So thinking about the prescription of this medicine, right? So pirfenidone, I think all of us have probably prescribed this at some point. And so you can see here, usually it's an up titration. We start at 1 tab 3 times a day for 7 days, then 2 tablets for 7 days, and then 3 tablets a day would be the final dosing. Now, this is sort of the guideline recommended, but there are also guidelines taking into account individual patients who may need a slower titration, for example, right, for side effect profile, or if you have an elderly patient who you're worried, may not tolerate the medicine, that you can go longer with the titration. So I've done all sorts of kind of creative ways of trying to, see if we can get people on this medication. And so you certainly can go longer with the up titration. We recommend that people take it with food. And then I had talked about the photosensitivity rash, and so skin protection is really important in people that are on this medication. So I talk to my patients, if I have people that love being outside and they're outside all of the time, you really have to talk to them about, is this the right drug for you, or how are you going to protect your skin? And so monitoring, sorry, this is a little bit, I know, a lot of wording here, but you get the idea is, hepatotoxicity for both of these medications is something that we worry about. And so in everybody, we get baseline liver function tests. And then there are guidelines that suggest checking the liver function tests once a month for every 6 months. Or for the first 6 months before moving on to once every 3 months. Some people may do it a little differently. I tend to be more conservative and check it once every month. And then, you follow what happens with the LFTs. And so you can sort of see here, there may be levels where it's elevated, but you're still able to monitor the patient on the medication. And then there may be other times where the LFTs are elevated, but they have symptoms associated with it. And that is usually a red flag that we need to pause and take a step back and make sure that we're not harming our patient with these medicines. And the other thing I have there at the bottom, other medications that have interactions, such as ciprofloxacin. We may have dealt with that a little bit with our patients. We have to really think about the interactions that this medication can have. And then nintedanib, our other antifibrotic, a little bit different in terms of not really necessarily up titrating, starting a patient 150 milligrams twice a day. There is an option to give people 100 milligrams twice a day as well. There are some people that we may start at the lower dose for a variety of reasons if we're worried about side effects or adverse events or other comorbidities. And again, taking with these medications with food is really important. And I think thinking about a lot of our patients, this isn't the only medicine they're getting, right? And so thinking about the other medicines and when they may need to fast with their other medications and how that interplays also plays a role in the decision making. And again, similar monitoring, and these are from the guidelines that have been written on how to monitor for these medicines, and these are what we follow in our ILD clinic. Again, baseline LFTs, and then checking once a month for the first 6 months, and then usually if they're tolerating okay, every 3 months after that. And again, we talked a little bit about how you may be able to monitor, and certainly if there's symptoms, you usually have the option to pause and either go back on a lower dose or talk with the patient and decide if it's worth continuing based on what their individual wishes are. And then there are obviously certain cases where the LFTs are very high, and we may consider discontinuing the drug completely. And then diarrhea, we've talked a lot about. It's a predominant symptom, so much so that oftentimes our patients are sent an antidiarrheal with their medicine, right? And so I always warn them that up front because I've had experiences in the past where they've been surprised about that. So I always warn people that you may get an antidiarrheal sent with your medicine. And so there's an algorithm for how to help people manage that. And again, I think that it's really individualized. Some people are willing to sort of accept that and manage it, and other people are not. And there are algorithms for how to do this. And I think the biggest way to think about it is we have to make sure that it's safe, right, and it's not causing any harm to them. And if they're able to manage it, then we can usually get them through that. And so I've alluded to this a little bit already, but managing expectations is a really important part of our job, right? And so what do we expect these medications to do? Reduce the rate of decline in lung function compared to people who are not on the medication. That's what our trials have shown. That's what the primary endpoint is in all of these trials. Reduce the risk of exacerbations, right? There's data to suggest that it may reduce the risk of exacerbations, which is a real risk in our patients with pulmonary fibrosis. What do we not expect it to do? I think that's also really important. Reverse fibrosis, improve lung function, and improve symptoms. Anecdotally, we may have a patient or two that tells us my cough is a little better or something once they're on the medicine, but in the trials, we did not see that, right? And so I think we have to be really honest with our patients about what we expect this medication to do. And then, again, the shared decision-making is incredibly important. And regardless, this sort of touches a little bit on our last talk, regardless of the decision to start an antifibrotic or not in our patients, there's a lot of other care that we have to be considering, and I did want to just throw this slide in because I think it's really important. Because we know that there's not going to be a great impact on symptoms, there might very well be side effects, and especially in our patients with idiopathic pulmonary fibrosis, the disease will progress, right? Maybe at a slower rate, but we expect that in a certain number of our patients it will still continue to progress. And so all of these other components of care we have to still consider and address as we're talking about the entire management plan. So things like symptom management, we talked a little bit about oxygen if it's needed, pulmonary rehab, palliative care, psychological support. It's really all part of the bundle, right, that we all do when we care for people with ILD. And so this is part of our team at the PFF Walk in New York City, which is a great thing for everybody that's near a walk. You should definitely join. And I want to thank you so much for having me.
Hi, thanks so much for having me in this session and for organizing a very nice session. Oops, too far. So I'm going to talk about treatment of hypersensitivity pneumonitis. Here are my conflict of interest disclosures. So I will review a little bit of the diagnostic criteria and also work them into kind of a case-based discussion of management considerations. I wasn't sure how much the first morning session talks would cover these diagnostic criteria specifically. So HP is the classic environmental lung disease. It includes an inflammatory and/or fibrotic disease that affects the lung parenchyma and small airways, and it typically results from an immune-mediated reaction provoked by an overt or occult inhaled antigen in susceptible individuals. So the diagnostic evaluation generally consists of taking an exposure history, which can include self-report, lab-based, meaning positive IgGs to mold or bird, or a combination. High-res CT has kind of become a mainstay of diagnosing this disease, as well as looking for bronchoalveolar lavage lymphocytosis, generally considered as about 30% or more of the white blood cells being lymphocytes, although there's not a strict threshold stated in the guidelines, as well as looking at histopathology and excluding other causes such as connective tissue disease. So it's important to think about leveraging diagnostic test results to guide prognostic expectations and management. So there's an example of a normal lung CT, non-fibrotic HP, which is really quite a different disease than fibrotic HP in terms of survival expectations, average survival more than 20 years with non-fibrotic versus maybe about 7 in fibrotic compared to IPF that has a 3.5-year survival. So there's a lot of evidence that fibrosis is associated with worse survival. This is stratified by whether they had non-fibrotic or fibrotic HP based on biopsy, another biopsy series stratified by organizing pneumonia, fibrotic NSIP or UIP, which do worse. CT fibrosis is also important to look for if you don't proceed to a biopsy. Study after study suggests that this one is the extent of fibrosis is associated with survival. And then finally, having honeycombing versus fibrosis with no honeycombing may also be relevant, where HP with honeycombing has a similar survival as IPF, whereas non-fibrotic HP without honeycombing does a little bit better than similar IPF patients without honeycombing. So I will focus most of this talk on fibrotic HP because we're in the Pulmonary Fibrosis Foundation Summit. These are the CT criteria for fibrotic HP. You're generally looking for at least one of the distribution features and then one of the small airway disease features to fit patients into typical, compatible, or indeterminate for HP buckets. This is an example of a typical fibrotic HP CT. You have some fibrosis. Not sure if I want to try to use the pointer, but there's some traction bronchiectasis and reticulation, as well as mixed ground glass. And then mosaic attenuation, which is this patchwork of differing attenuation throughout the lungs. And then histopathology is also bucketed into typical, probable, or indeterminate. For fibrotic HP, you're looking for a background of chronic fibrosing interstitial pneumonia, which is described a lot like UIP-like or fibrotic NSIP-like patterns. To be typical HP, you need to see poorly formed non-necrotizing granulomas. They list some features that may be present, including things like cellular interstitial pneumonia, and then features that aren't present because they suggest other diseases. So I have some example pictures. This picture, I believe I zoom in on some. You have some relatively normal looking airways, although many of them have a little bit of expansion by inflammatory cells, as well as a fair amount of pink collagen fibrosis. This is zoomed in to demonstrate cellular interstitial pneumonia, so these blue lymphocytes expanding the interstitium, and then a granuloma here. And it's not uncommon in fibrotic to see fairly mixed patterns. So the arrows point to some, sorry, I shouldn't use the pointer, some more dense collagen fibrosis, and then microscopic honeycombing that can look a lot like UIP, IPF, but then in the same patient, a different spot, you see some more of these cellular interstitial pneumonias in a giant cell. So the main treatment tools we have for HP are antigen remediation, medications, and identifying and managing comorbidities, which I won't really go too much into because I think those were pretty well covered in some of the other talks. So case one is a 68-year-old woman with progressive shortness of breath for 3 years. She keeps a cockatiel in her bedroom for the last 15 years. She has probable UIP on a CT. She had a BAL first that showed 8% lymphocytes, and then ended up proceeding to a surgical lung biopsy that actually just showed UIP with a little bit of minor chronic inflammation, which if you look at the guidelines is not inconsistent with UIP. So she kind of fits into what we currently call HP not excluded. She has an exposure, but she doesn't have lymphocytosis or classic features on histopathology. So there is some evidence that a patient like her is going to have disease behavior that looks a lot like IPF. So this is an old study, but I still find it very well done and informative. These are biopsy-proved chronic pigeon breeder's lung or chronic HP that have pretty good survival time versus UIP on biopsy with bird exposure, and then UIP, IPF with no bird exposure have similar prognosis. There's also the Panther trial, which enrolled IPF patients, but didn't really have a central review of CT or a central review of exposure history. And it was actually stopped early because of increased risk of mortality in patients treated with a combination of prednisone, azathioprine, and N-acetylcysteine. So those are kind of the data that drive me to a diagnosis actually of IPF in a patient like this. I still generally recommend avoiding exposures that may potentially be harmful, and I offered this patient antifibrotic treatment without waiting to observe progression. And then other general ILD care, things like pulmonary rehab, testing for need of oxygen, considering lung transplant in inappropriate candidates, and then palliative care. So I submitted this talk before some interesting new data came out, but there is evidence to suggest that HP antigens, as we think of them, things like pigeon breeding, farm work, bird exposure, cause non-HP diseases, including IPF, preclinical or subclinical disease, or fibrotic ILD in general. These are HP studies that suggest that identifying an antigen as well as ability to avoid antigen exposure. So the green line is antigen unidentified, the red line is antigen identified but couldn't avoid it, and then blue line is antigen identified but could avoid it. So that appears to have a difference in survival when you can identify and avoid an antigen. There was one study that came out actually just like in the last week or so that suggested that this may not quite be true in other diseases besides HP. So there wasn't really a survival difference in IPF, but all of this is sort of observational, low quality data. I still generally try to look for exposures and recommend avoidance. Sorry, that picture didn't make it into this talk, which I submitted a little longer ago. And then a little bit more information about antigen avoidance. Levels of avian antigen actually take time to come down after a bird is removed from the home, so just keep that in mind. these are general guidelines I suggest to patients: cleaning up mold or water damage, looking in and cleaning out air ducts and filters, removing birds, and looking for nests, particularly if they're like in the home or near like air intake, as opposed to just out in the yard, which probably is not harmful. Thinking about professional cleaning if possible, and then revisiting potential exposures during follow-up and monitoring. So case 2 is a 68-year-old male with progressive shortness of breath and cough for about a year and a half. He needs 2 liters of oxygen at rest and 3 liters with exertion, and he has no relevant exposures. The high-res CT shows mixed reticulation in ground glass and fairly prominent mosaic attenuation throughout. And I'm not showing you the craniocaudal, but he has a diffuse distribution on both axes. He had a BAL that showed 28% lymphocytes, and a biopsy was considered too risky because of his oxygen needs. So depending on where you think that lymphocytosis falls, he is fitting into a typical CT pattern, does not have any exposures, but probably does have relevant lymphocytosis. So he'd either be kind of a low to moderate competence HP diagnosis. So medications to think about for treating HP, there's a single randomized controlled trial that I'm aware of that enrolled patients with acute farmer's lung. This study's old enough that they didn't report or maybe didn't even have high-res CT results. They administered an 8-week course of steroid, and they demonstrated that steroid treatment, which are the filled-in circles on FVC and FEV1, kind of hastened improvement in the lung function, but even the untreated patients did improve over time and eventually kind of ended up in a similar place in terms of lung function after 12 months. There are a couple of observational studies that might inform how we expect the lung function to change after initiating steroids. So these studies show that the non-fibrotic HP group after initiation of steroids, sorry, these numbers are very small, but time 0 is where the green line comes in. That's when they initiated treatment. The non-fibrotic group, which is on top, had a little bit of bend upward, especially in the FBC, but maybe stabilization of the DLCO relative to their pretreatment trajectory, whereas fibrotic HP actually kind of continued on a similar trajectory. This study looked at initiation of mycophenolate mofetil, or azathioprine, and found a possible upward bend in the DLCO, although not so much the FVC after time 0 treatment initiation. And there is a little bit of evidence that using steroid-sparing immunosuppression along with steroids might reduce the risk of adverse effects. So the prednisone-only group has kind of a almost skyrocketing rate of adverse effects, whereas the people who started steroid-sparing agent had adverse effects, but not as much as prednisone alone. There is a little bit of data that steroid-sparing immunosuppression may be harmful, or perhaps people just don't respond to it as well if they have short telomeres. So the Q1 is the lowest length of telomeres in this graph, and you can see that adding mycophenolate doesn't really impact their survival, whereas the longer telomere group, the mycophenolate added group, have the best outcomes, whereas the no mycophenolate have a little bit lower survival. Bear in mind, this is all observational data. I realized I didn't put a guideline on dosing or monitoring in my slides as Carrie was giving her very nice talk. I apologize for that. I usually follow kind of the transplant treatment dosing and monitoring schedule. So patients on CellCept generally need to have CBC monitored. Some people also monitor liver and kidney function. People on Imuran need both liver and CBC for bone marrow suppression monitored. So getting back to diagnosis and recommendations on this case, it's a 68-year-old male with symptoms for a little while who needs oxygen at rest, and exposure can't be identified and avoided at this time. So options for when to initiate medication treatment. If I'm not going to initiate treatment right away, I'm usually looking for more mild disease, or if a clear-cut exposure can be identified and avoided. Whereas if I'm going to use steroid-sparing immunosuppression plus or minus prednisone, I'm looking for people who have a lot of symptoms, moderate to severe disease, or those who have already showed progression during observation. I tend to avoid prednisone alone, even for like an initial challenge. If I'm going to start medication, I usually start them together. And I consider the plus prednisone if the patient needs oxygen or rapid progression, whereas if a patient has been relatively stable recently and I'm just starting treatment to see if it'll improve kind of chronic symptoms, I usually start without prednisone. So this is actually technically not the same patient, but a similar patient who got diagnosed over on this side of the graph with a surgical biopsy. He actually elected not to be treated, even though he had relatively low lung function, DLCO around 50% are predicted. He came back a couple of years later. This was like 2020, and then he came back in 2022 having shown a pretty steep decline in his lung function. At that point, he initiated CellCept and prednisone. He had kind of a modest improvement that was sustained for a little bit, but then ultimately showed progression, again, even on treatment. So he initiated OFEV and was referred for transplant at that point. So you had just a great talk on immunosuppression, progression, and when to think about initiating antifibrotic drugs in HP patients. In general, I don't like to initiate steroid-sparing plus antifibrotic together because they have a fair amount of overlapping side effects. And I think the jury's still out a little bit on which one to reach for first. I tend to favor steroid-sparing immunosuppression in patients who have a fair amount of inflammatory change, like on their biopsy or clear-cut BAL lymphocytosis, whereas someone who's a little bit more fibrotic, I might avoid that and reach for antifibrotics at first. So just a quick summary, looking for ongoing exposures and recommending avoidance and cleanup is highly relevant, especially for people who have a guidelines diagnosed HP. Immunosuppression considers drugs targeting abnormal cellular lymphocyte immunity, which makes the most sense with this disease, but with a low quality of evidence, and avoiding steroids alone, particularly in chronic fibrotic HP. And then antifibrotics are useful for progression observed on treatment or progression observed on its own. I think that's my last slide.
Good morning. Good morning. You're almost there. It's a long morning. I've been dreading this thing all morning, watching my colleagues struggle. We'll see how this goes. These are my disclosures. So we've had some remarkable talks covering some of this in broad strokes. I'm going to dive a little bit deeper into the treatment. You can't treat connective tissue-associated lung disease unless you first made the diagnosis. So even though I have to talk about all the connective tissue disease-associated ILDs and their treatment in 18 minutes, I'm actually going to take a few slides to mention the importance of actually making the correct diagnosis. Because although 80% of my patients have a CTD ILD, 80% of them were actually referred to me with a diagnosis of IPF. So I think it's really important to emphasize that you have to first make the diagnosis to effectively treat it. We know ILD is incredibly prevalent in these conditions. Depending on the series and how the diagnosis is made, you can see that here. And we also know, based on some great lectures already given today, that the lungs can be the first organ affected in up to a quarter of the time, sometimes more. I'm just going to highlight some of the ones in red today, but the approach is similar for all of these conditions. So making the diagnosis. Now, Dr. Wilfong, in another one of her amazing lectures, she's always that good, I assure you, focused on how subtle it can be to make the diagnosis, right? It's not always this obvious. Actually, some of these pictures I took from Dr. Danoff, who's sitting here. And I think the point was also made that we have to have a low threshold to order serologic panels or the myositis panel. And this study here just emphasizes this, that in a retrospective study of 165 patients with idiopathic ILD, a large percent of them which were referred with a presumed diagnosis of IPF, up to a quarter of them actually had a positive hit on their myositis panel. Now, keep in mind some of the caveats that Dr. Wilfong went into in detail. You have to keep in mind which antibody is positive, the clinical correlations, et cetera. But the point is, if you don't look for it, you can miss it, especially when the clinical findings are subtle. So we have to keep our eyes open and make sure that we're not missing an underlying connective tissue disease in our patients with ILD. So after that, when we've made the diagnosis, how do we approach these patients? How do we treat them? Now, spoiler alert, the data is not robust. We don't have massive, randomized, prospective, double-blind, placebo-controlled trials for the most part for most of these specific conditions. However, the data is growing, and we're starting to get a little bit of the signal through the noise. Allow me to show you what we have. So first, I show you this. This is a randomized control trial. This is a phase 2 study. It's pretty recent. Looking at patients who have a smattering of connective tissue diseases. So they had myositis, scleroderma, mixed connective tissue disease. And this study was looking at rituximab versus cyclophosphamide. I point this study out primarily just to say we don't have to use cyclophosphamide necessarily, or cyclophosphamide isn't necessarily more potent, better, just because it's IV or more toxic, et cetera. So this is essentially a non-inferiority study of rituximab. There was no difference between the two in forced vital capacity at 24 or 48 weeks. And you can see that both agents were effective at improving lung function. There's also no difference in infection between the two groups. We'll start with RA-ILD. This is maybe one of the conditions we're most common or most comfortable seeing. This was a retrospective study, and here patients received either azathioprine, mycophenolate, or rituximab. Again, there was no treatment difference between groups. There's this notion sometimes that rituximab is more potent or azathioprine is less effective. Some people prefer mycophenolate because it's easier to use or better tolerated. But again, we don't have strong data that one agent is better than another in this patient population. And this is a common theme from all of these studies. Again, most of them are retrospective. You can see a lot of these patients are on concurrent therapy, so that makes the data a little bit messier. But I think it's notable here that the trend lines in vital capacity and diffusion capacity were downtrending until treatment was received, and then the trend lines start to improve a bit, or at least stabilize out. So it is possible to improve or at least stabilize lung function in patients who have RA-ILD. What's really important, I think, in this study is that it doesn't matter what the pattern of lung disease is. So even patients who had a UIP pattern of disease got benefit from the use of immunosuppression here, implying that there is still an underlying inflammatory component, and so it may be worthwhile at least giving a trial of immunosuppression to some of these patients, even if they have this sort of classic RA UIP. In patients with RA, a lot of patients are starting to get agents such as abatacept. Again, we don't have prospective data, but at least retrospectively, the larger cohorts of patients who have received this agent, we can start seeing impacts on lung function in them retrospectively, and abatacept does seem to be able to at least stabilize or sometimes improve lung functions in these patients, so I do think it's a viable option. We have some data looking at the use of pirfenidone in patients who have RA-ILD. The TRAIL trial was a randomized controlled trial. Unfortunately, did not meet its primary composite endpoint, in part because there were recruitment issues because this came out during COVID. But secondary endpoints looking at slower estimated annual rate of FVC decline, -66 versus -146. So there's a signal here that pirfenidone probably slows down FVC decline in patients with RA-ILD. We talked about scleroderma previously and immunosuppression in those patients. I'll dig a little bit deeper here. So the scleroderma lung study 2, this was a landmark study that gave us our first glimpse into the use of mycophenolate for patients with scleroderma. Previously, the scleroderma lung study 1 showed us that the use of immunosuppression in general in this population was useful. This was using cyclophosphamide, and that showed stabilization and some improvement in these patients. But cyclophosphamide is toxic. You can't keep patients on it forever. And so after 2 years, the effect was lost. The scleroderma lung study 2 shows that using mycophenolate is as effective as cyclophosphamide over this period of time. And so after this study, mycophenolate became sort of the standard of care immunosuppression in patients with scleroderma. We also had mentioned in another wonderful talk about the use of antifibrotics in patients with scleroderma, and this is the Census trial, where the use of nintedanib does slow the rate of FVC decline in patients with scleroderma. Now, interestingly, even if you're on mycophenolate and you're immunosuppressing, the rate of FVC decline is still there, albeit not as much. One of the criticisms of this trial, or the utility of using nintedanib in patients with scleroderma if they're on immunosuppression, is that the rate of FVC decline is not as robust. So you can see here, -40 cc's a year versus -66. People who push back on this criticism would argue if you're a 50-year-old woman with scleroderma, losing 30 cc's of lung function a year actually matters because it starts to accumulate rather quickly for your age. So this also has become relatively standard of care for patients who have a significant fibrotic component of disease, as was discussed. The FOCUS trial, now this is a trial looking at the use of tocilizumab, anti-IL-6 therapy in patients who have scleroderma. Now there's some caveats here, because this is a hot topic, this is a hot new drug, you're gonna hear a lot about this in the community, but a few things I think worth pointing out, and I'm gonna get into this a little bit here. So this was a phase 3 study of diffuse cutaneous scleroderma. These patients had active disease, elevated inflammatory markers, and about 2/3 of them had ILD. Now, the primary endpoint was skin changes, right? So this was not a study of ILD, but a lot of patients had ILD, and so they looked at that as a secondary endpoint. And what they noticed in their study was that the absolute decline in FVC of at least 10% was much less in the tocilizumab group versus placebo, and you can see the graph here. So it's a very pretty graph. And so the conclusion was that this is actually an effective agent to treat early onset scleroderma ILD. But I want to point some things out here. And so this is a summary of the known scleroderma trials. And because there's a lot of rhetoric that tocilizumab is good and useful for patients who have early onset scleroderma ILD, mycophenolate is useful for patients who have more advanced or late onset ILD, and that is not what this data suggests. And so let's break down what we actually have here, because I think it's important to know what the data shows and what the data does not show. If you look at the scleroderma lung study 2, which is mycophenolate versus cyclophosphamide, if you look at the census trial, which is nintedanib versus placebo, and you look at the focus trial, which is your tocilizumab versus placebo trials. If you look at the mean age of the patients, you'll see our focus trial, patients are younger. If you look at mean disease duration, you'll notice focus trial, the disease duration is much shorter, so this is a newer disease onset. And you can also notice that patients in the focus trial have much less severe disease, right? Significantly so. There's also a note here, patients were receiving immunosuppression with mycophenolate in the census trial. So patients with early disease were treated in the focus trial, but that does not mean that tocilizumab is more effective at treating early onset disease. The focus trial, patients had stabilized disease despite the fact that their disease was less severe. In the scleroderma lung study 2, despite the fact that disease was more severe, FVC was actually improved and then stabilized. That does not mean that mycophenolate is less effective for early onset disease as well, right? So that's an important distinction to make. Something tells me we're not going to have a head-to-head trial of tocilizumab versus mycophenolate sponsored by the drug companies. I think all we can say is that we have now 2 agents that probably are potentially efficacious in treating scleroderma ILD, and tocilizumab is probably something else we can add to our toolbox. But new onset ILD in patients with scleroderma, I would not say we can make an argument that we should choose tocilizumab over mycophenolate based on this data. But you will hear this in the community, and I just want you to keep your antennae up. What about rituximab? Vitamin R in the rheumatology world. So this is also an option. We use this for refractory disease. It treats the joints concurrently, so it is an attractive option. Again, there are not large prospective randomized trials, but there is growing retrospective data demonstrating that it can be useful in stabilizing or improving lung function in patients who have scleroderma. So what about myositis? Again, retrospective data demonstrates whether you're using cyclophosphamide, azathioprine, mycophenolate, it can be stabilized or improved with these agents, and it's an effective steroid-sparing agent. But again, they're all pretty similar in their efficacy. Cyclophosphamide is not better just because it's more toxic, so there's no reason to necessarily reach for that, regardless of how sick patients are. There was talk about tacrolimus. Again, there is data to suggest that tacrolimus can be effective. There's certainly plenty of large case series, retrospective data supporting its use, especially in sick patients coming out of Asia, where they tend to use a lot of tacrolimus. There's potentially some reporting bias here because they have a lot of publications coming out of that region and they use a lot of tacrolimus. It doesn't necessarily prove that it's more effective than other agents used, but I think there's growing evidence that it's useful. We've certainly had good experience using it in some of our sicker myositis patients. Rituximab versus cyclophosphamide for myositis. Certainly data to support that it's non-inferior, potentially more effective, certainly less toxic. Tosafitinib, so these are some of the newer JAK kinase inhibitors used in rheumatoid arthritis. And now there's some growing evidence in case series using this for some of the sickest patients with Some hesitation with some of these agents because they do carry a black box warning for severe cardiovascular events and stroke. But there is some evidence that they could increase survival. So I think we need to do more study on this agent. But when you have patients who are dying in an ICU, it starts becoming an attractive option. So stay tuned. I think you're going to hear more about this, and hopefully we'll have more robust data. But I think this is worth at least mentioning here, that these are things that are coming down the pipeline. We've already had a remarkable lecture on the use of antifibrotics. I'm not going to get into the details. Suffice to say, there is evidence that we use antifibrotics in non-IPF progressive fibrosing lung disease, slows the decline in FVC. It's worth mentioning here that about a quarter of these patients did have an autoimmune disease or an autoimmune subtype. Myositis was not represented here, and this is because of study design. So immunosuppression was not allowed in this trial. So myositis patients are not represented here. But there are ongoing future trials, and so I'll give just a shameless plug for the last trial here, the MINT trial, which is currently enrolling. As a disclosure, I'm on the steering committee for that trial and one of the PIs, so keep that in mind as I pitch it. But that's looking at the use of nintedanib specifically in patients who have myositis to try to answer that question. But I think the future is bright. 10 years ago, we knew very little about some of these mechanisms and had very few clinical trials. Now there are a plethora of phase 1, 2, and 3 trials in the works for progressive fibrosing ILD. So, in summary, we know ILD is common in this patient population. Signs of autoimmunity can be subtle in these patients. The mainstay of treatment is immunosuppression. And I think getting into the weeds of dosing and titration and timing of that lends itself to a robust Q&A session, which we will have after one more fabulous lecture by my colleague, and we can talk about that. We also talk about using antifibrotics, and we had another wonderful lecture on that. I will say just briefly that we use them concurrently with immunosuppression quite commonly and tend to stagger starting them so as not to confuse side effects, which was also very eloquently stated previously. But we need more data. We need more studies. And fortunately, we now have the interest of researchers and pharmacy, and hopefully the future will be brighter. So thank you for your attention.
I like the introduction. I got the last fabulous talk, so that puts a bit of pressure on me to give a fabulous talk. And I have 3 6-minute walks to tell you all about PH-ILD, diagnosis and treatment. These are my disclosures. And I will mention some of these, most of which are off-label in the context of PH-ILD. So objectives are to talk about the implications of pH complicating interstitial lung disease, when to suspect pulmonary hypertension, and then I'll end off with a treatment approach. So I think most people are familiar with the World Symposium classification of pulmonary hypertension. Interstitial lung disease sits under group 3, pulmonary hypertension. And definition of pulmonary hypertension, this is very much a moving target, which sometimes can be a little bit frustrating, because before 2018, this was a definition, MPAP of 25 or more, accompanied by a PVR of 3 or more Wood units. And then the World Symposium happened in 2018, and the powers that be decided to change it and say, no, we're going to take the MPAP threshold down to greater than 20 millimeters of mercury, keeping the PVR the same. Then our European colleagues just last year said, we're going to do a little bit better here, and we're going to lower the PVR down to greater than 2. So that's where we sit at the moment. Whether or not the World Symposium, which is happening next year, the 7th World Symposium, will adopt this newer definition remains to be determined, although I suspect they will. If we talk about the epidemiology of pulmonary hypertension complicating ILD, and most of this is historical data based on the old pre-2018 definition, the prevalence ranges from as low as around 8% to as high as 86%, so a very wide range. And it seems like it's almost inevitable that if you look at that 86% number, that most patients will develop it depending on when you look for it. So it's a spectrum once again. If you look for it earlier, it's going to be 8 to 15. If you look for it very late, it's going to be closer to the 86%. The problem with PH complicating interstitial lung disease is that it's insidious, because if you look at the main symptom of ILD, it's shortness of breath. The main symptom of pulmonary hypertension is shortness of breath. So they share the same kind of endpoint in terms of patient symptomatology, and it's difficult to know when progressive shortness of breath is due to progression of the ILD versus interceding pulmonary hypertension. One important point around that, and this leads into this slide, is that you shouldn't wait for overt right heart failure, because most of the patients who develop pulmonary hypertension tend to have mild to maybe moderate pulmonary hypertension, as seen in this histogram distribution. About 50% of the patients who have pulmonary hypertension from this particular study had MPAPs of 25 to 30. If you wait for evidence of frank right heart failure, it's not going to happen, because for the most part, patients are going to die before that happens. Now, if you look at the outcomes of patients with pulmonary hypertension versus those without, you can see that there's a marked difference in terms of outcomes, even though most of these patients had more mild pulmonary hypertension. So any pulmonary hypertension is a bad thing. This is from a Spanish registry published more recently last year, looking at patients with no pulmonary hypertension versus borderline versus mild to moderate versus severe. And as you can see from this Kaplan-Meier plot, any patient or all patients with any form of pulmonary hypertension have a similarly dismal prognosis. If you look at the median survival, it's around 18 months. And I think a very important distinction is divorcing mild PH from severity of disease. Even if you have mild PH, you have severe disease, because any patient group with a median survival of 18 months has severe disease. And this gets into the concept of when to treat, which we'll come to towards the end of the talk. This is a paper from our group many years ago looking at 6-minute walk in those with and without pulmonary hypertension. It's a subgroup analysis from that survival curve I initially showed you. And what you can see here is that pulmonary hypertension has implications for patients' functional ability. They walk less, they desaturate more, have a greater mortality. But this is the first clue, or one of the clues, that we have to the presence of pulmonary hypertension. Many of us, I think most clinics these days, will get 6-minute walks, and if patients desaturate more, if they get more short of breath during the walk, if they require more supplemental oxygen, these are all clues to the presence of underlying pH. When we look at the CT, we typically look at the parenchyma, but staring us right in the face as well is the pulmonary artery segment, and you can look at the pulmonary artery segment in relation to the ascending aorta, and if the ratio is greater than 0.9 or 1, then that might be another indicator of underlying pulmonary hypertension. So all these things we get anyway. And if you look at it and put it all together, first of all, the history is very important. If you get a sense that the shortness of breath is more or is disproportionate to the underlying extent of disease, think pH. Always listen for that loud P2 heart sound. The DL, the lower the DL, the more likely it is that the patient has pulmonary hypertension. You can look at the FVC to DL ratio, and the higher that is, in other words, preserved lung volumes and lower DL, more likely it is that they have pulmonary hypertension. We spoke about the walk distance, imaging. We have our biomarker in the NT-proBNP, which you can get as a matter of routine when you check their routine labs. And then, of course, we have echo as the best screening tool, but it's not the way to make the diagnosis. So as we put all this together, we develop a pretest likelihood based on our suspicion of disease. Are we very suspicious, high suspicion, low suspicion, or no suspicion? Get the echo, and then contextualize the echo in relation to the clinical likelihood to make a decision whether or not to proceed with a definitive right heart cath. And you always need a right heart cath for any form of pulmonary hypertension to make a definitive diagnosis. I will say that sometimes my clinical index of suspicion is so high that it doesn't matter what the echo shows, I'm still going to go ahead and proceed with a right heart cath. And this underscores that point in terms of not only can echo overestimate what the true pressures are, but in some cases it can also actually underestimate what the pressures are, especially if you're looking at an outside echo where they haven't paid enough attention to the right side of the heart. So to go through all the meds we have available for Group 1 PAH, and we have many, these are all the meds that are currently approved, and the more toys we have to play with in Group 1, it becomes more enticing to say, well, what the heck, let's try them in Group 3, and that's what we've done over time. The concept is rather simple. If patients have a breathing limitation, is it due to the lung disease or is it due to the pulmonary hypertension? And if it's due to the pulmonary hypertension, can we do this, treat them with a pH drug, and improve their breathing limitation so that the parenchymal lung disease then becomes the limiting factor? I have a couple of tables of all the studies that have been done. I'm not going to talk about them all. I have them color-coded. Green is good, yellow is equivocal, red is going to be bad. But what you'll notice is most of them are small, retrospective, open label, single center, some more of the same. And these are the few RCTs that have been done, and I'm going to talk about at least two of them. We can take the second one from the bottom off the table. Inhaled nitric oxide didn't pan out in the phase 3 study, and that data was released about a year ago. The paper is pending submission at this time. And I'm going to talk about two of those, but before I get to those, I'm going to talk about another important concept in terms of bundling these patients together. What you can see to the left is the slide I've shown you already in IPF, and to the right are patients with chronic hypersensitivity pneumonitis who have with and without pulmonary hypertension. And if you compare the outcomes of those with pulmonary hypertension, they're almost identical. So it appears that once patients develop interceding pulmonary hypertension, it's the pH that drives the outcomes and not the underlying primary parenchymal lung disease. And this concept is depicted here, that there might be this inflection point where pH, or the pulmonary vasculopathy, intercedes and becomes the driver of outcomes. Let me skip through that quickly. I try to hide some of these slides because I knew I only had 18 minutes, so I'm not going to talk about that. Let's talk about the study that I was alluding to. This is the RISE IRP study. I had the privilege of being the chair of the steering committee for the study. This was riociguat in idiopathic interstitial pneumonias. These were the demographics of the patients who were enrolled in the clinical trial. You can see the breakdown there, kind of similar to what we see in some of the other studies. And we thought we were getting the right patients in here. They had mild restriction, more moderate pulmonary hypertension, and then, as you can see from the demographic table, then what happened is, as the chair of the steering committee, I got the dreaded call from the chairman of the DSMB, who said, you need to get on the teleconference with the sponsor in 1 hour's time, and that's never a good thing. And sure enough, they recommended that the study be stopped. Why was that? Well, there were more deaths in the treatment arm versus a placebo arm. Now, the numbers aren't huge here, 8 versus 3, but what concerned them more was that many patients who were formerly on placebo were getting rolled over to open-label drug, and those patients were dying. So they rightfully called a halt to the study. This was my reaction. Oh, no. But my real reaction was WTF, which stands for withdrawal therapy fast. Not what you were thinking, and all patients were taken off therapy within 24 hours. So why didn't we foresee this? And here are the 4 C's. Did we have the wrong patients? Did we have the wrong drug? Did we screw up in the study design? Or is the whole concept wrong? Is the notion that we should be treating pH-complicating ILD false, and that it's an adaptive phenomenon rather than a maladaptive phenomenon? The great tragedy of science is slaying of a beautiful hypothesis by an ugly fact, but the secret of success is to go from mistake to mistake without losing your enthusiasm, which we did as a community. And we moved from that very quickly to inhaled treprostinil in pH due to ILD. This was published in the NEJM in March of 2021. I think most people are familiar with the design of the study. This is the demographics of the group who got enrolled. And I apologize, I meant to hide some of these slides. This is just repetition. The population was very similar to the RISE-IP population. A sick population, about 3/4 of them were on supplemental oxygen. And the primary endpoint was a 6-minute walk test, which was positive by 31 meters, placebo-corrected, at 16 weeks. Most of this driven by improvement in the treatment arm, 31.12, and this was my reaction at that time. We also had a very important secondary endpoint in time to clinical worsening. That was a composite endpoint, and you can see the components there: cardiopulmonary hospitalization, 15% decrease in the walk distance, all-cause mortality or lung transplantation. And we hit on this secondary endpoint of time to clinical worsening, which was great over a 16-week period. It's great when you hit on your primary, even better when you hit on your most important secondary, but the cherry on top of the cake was biomarker evidence that supported the clinical benefit. And this was seen with the NT-proBNP, which went up in the placebo arm and went down in the treatment arm, suggesting that there was less RV strain. So on March 31st, 2021, as most people are aware, the FDA approved inhaled treprostinil for the treatment of PH due to interstitial lung disease. And I think this really does represent a paradigm shift in how we think about our patients in terms of, you heard great talks, fabulous talks about different approaches to fibrotic lung disease. So you can layer on these treatments that treat the fibrosis. If there's inflammation, treat that. But be on the lookout for PH, because you can also intercede with another therapy that can really help these patients, in fact, improve them, as you saw on the 6-minute walk. It's not very often we can improve patients who have fibrotic ILD. Let me skip through that one. I think a lot of the fun begins when you start doing some of the post-hoc analyses and you're looking at a very robust, well-collected data set. And we've had a number of publications looking at the data in different ways. I think the one that's got the most attention is one of our safety endpoints, which was lung function at the end of the 16 weeks. And to our very pleasant surprise, it went directionally in favor of inhaled treprostinil. That's for the total cohort, for the IIP patients, and for the IPF patients. And this is actually very replicative of what we see with pirfenidone and nintedanib. In fact, if you look at the absolute risk difference between placebo and treatment at 16 weeks, it's about the same as what you see with those other antifibrotics at 52 weeks. But what's interesting is that the treatment arm is above the 0 line, suggesting maybe that there is a little bit of improvement, or at least physiologic improvement. Of course, this is post-hoc, and currently underway is the TETON study, looking at whether or not inhaled treprostinil has independent antifibrotic properties. So this is, kind of appealing data, but we have to wait for the phase 3 study to know for sure. I think what really raised some further eyebrows is what happened to the FVC when the former placebo arm got rolled over to open-label inhaled treprostinil. And this is what happened. Actually went up once again. So this is more enticing evidence that there might indeed be an antifibrotic effect of inhaled treprostinil. Let me skip through that just in the interest of time, and that in the interest of time, because I think we're running low. Yeah. Let me present to you a treatment algorithm that I think is a reasoned approach for patients with PH-ILD. Now, you can take all these new definitions, and we can't apply that to the increased data set because the increased study was under the guise of the pre-2018 definition, MPAP 25 or more, PVR 3 or more. We need to study these folks to know if we should treat them or not. So further studies are awaited. But if patients qualify for pulmonary hypertension as per the increased criteria, then we have one approved drug, and that's inhaled treprostinil. Of course, we need to check for comorbidities, address those, treat those, refer to an ILD or PH program, transplant referral if patients are appropriate candidates. I showed you the very poor prognosis even with mild PH, so the two can happen concomitantly, treatment and referral to a transplant program. If they're intolerant of inhaled treprostinil or it's unavailable, You can consider a trial of sildenafil. There is mixed data on the use of sildenafil. I'm guilty of using this off-label myself in select cases. Each patient is an N of 1. If they feel better, great. If they don't, or if they feel worse, you take them off the drug. And then you do have those patients who develop more severe pulmonary hypertension, where more aggressive therapies might be warranted, where we would regard them as more of a PAH or group 1 phenotype. And these are contraindicated. Ambrisentan I didn't talk about, and Rio I did, Rio Sigward. And that's all I have. Thank you all very much for your attention.
All right. Well, thank you again for the invitation. It's always tough to follow lunch, but I was grateful for an interruption between me and Steve Nathan. I try to never follow him in a talk. So we're going to talk a little bit about lung transplant today, kind of the current state of the epidemiology of lung transplant, and then when and who to refer for lung transplant. So these are some disclosures and conflicts of interest. So I'm a speaker for United Therapeutics Altavant in the past, and have been to some advisory boards. So this is what we'll talk about today. So I was going to give you guys, start out with a little history of lung transplant. So lung transplant's been around longer than you might imagine, since about 1963. So 60 years ago this year, the first lung transplant was performed. Unfortunately, the recipient only survived 18 days. They ended up dying from renal failure and malnutrition. That same year, Martin Luther King Jr., I like to think of as the other Dr. King, gave his I Have a Dream speech. And then in 1981, the first successful heart-lung transplant was performed for a patient with idiopathic pulmonary arterial hypertension. That was the year the IBM 5150 computer, like the first personal computer, came out. And then in 1983, the first successful single lung transplant, which was done for IPF, was performed. That year, Cabbage Patch dolls were a big thing, apparently. In 1986, the first double lung transplant was performed for a patient with emphysema. And at that time, Mike Tyson was ravaging other boxers. And so hopefully we can knock out IPF the way that Mike Tyson was knocking people out in the mid-'80s. So a lot of what I'm going to talk to you about comes from the International Thoracic Organ Transplant Registry report from 2021 to kind of update the statistics. But wanted to point out to you that lung transplant numbers have been steadily increasing. So the column on the left is kind of the 92 to 2000 era, and on then 2001 to 2009, and then on the far right, 2010 to 2018. And you can see the numbers have increased significantly over time. And that's the case is also true in North America, not just worldwide. This is another way of showing that same concept, and you can see really bilateral lung transplants have taken off significantly. The green at the bottom are single lung transplants, and most patients receive bilateral lung transplants now. That's been really the trend, and bilateral lung transplants in almost every condition seem to be associated with improved outcomes. This is U.S. data. I wanted to just define, if someone asks, like, how many lung transplants are we doing a year in the U.S.? It's about 2,500, and only about 40 to 50 heart-lung transplants. Again, the lung transplants for IPF are increasing, particularly in North America. You can see here the patients in green represent IPF, and if I can make my pointer work, this is the IPF bar in the current era in North America. So it's now the #1 indication for lung transplant. And this is another graphic that shows that same concept. And so in this slide, the blue represents IPF, and over time, idiopathic pulmonary fibrosis has overtaken COPD as the #1 indication for lung transplantation. That smaller yellow arrow is other forms of interstitial lung disease. So you can see combined IPF with other forms of interstitial lung disease really make up a large percentage of the transplants being performed. So again, transplant numbers are increasing, more patients getting bilaterals, and then interstitial lung disease accounts for the largest percentage of transplants. What about survival? How does that look over time? So this slide shows data from 1992 to 2017, which is kind of the most updated survival data that for kind of all comers that's available. And you can see the median survival for a double lung transplant is about 7.8 years. Conditional means if you lived a year, how long would you live if you're able to survive sort of early post-op issues in that first year, and that's about 10 years for all comers with all different diseases. And there's some conditions that perform better than others, and I'll get to that in a subsequent slide. So this is by era, and you can see the blue here represents the most recent, the 1992 through 2001 era, whereas the red and green are the more recent eras. Not much movement in terms of improvements in outcomes since 2001, kind of overall. And so kind of marginal improvement over time in outcomes. And we'll get to some reasons why that might be in the coming slides. So what about particular disease states? You can see the interstitial lung disease that's not idiopathic interstitial pneumonias is in red here, and there's a dark blue that's IIPs, and so this is for IIPs, the survival is about 5.2 years, and then interstitial lung disease, not IIP, it's about 6.7. So median survival is lower for patients with interstitial lung disease than some of these other entities like cystic fibrosis and idiopathic pulmonary hypertension. Looking at this slide, this is conditional survival for patients broken down by diagnosis. And so if you survive a year, idiopathic interstitial pneumonias live about 7.3 years, and other ILDs about 8.5. So how about if we kind of hone in on idiopathic interstitial pneumonia, which includes IPF? Do singles do better or worse than bilaterals? And you can see survival is not quite as good for single lung transplants. It may be that programs elect to do single lung transplants in older recipients, sicker recipients that maybe don't have the luxury of time to wait for a reasonable bilateral offer, or it may just be that bilaterals do better in general. But the survival is improved in bilateral, and this is other forms of interstitial lung disease are not IIP, and that same concept holds true. Bilateral lung transplants seem to do better. So key points on survivals, again, if you take all comers, it's about 8 years post-lung transplant mean survival for bilaterals, and about 5 years for single lung transplants. We haven't moved the needle much in improvement in outcomes over time. Idiopathic interstitial pneumonia has the lowest median survival of the various diagnoses at 5.2 years. It's a little better for other forms of interstitial lung disease at about 6.7 years. And again, some of that may be because these are patients with connective tissue disease that may be younger, they may have fewer comorbidities. And then regardless of the cause or underlying disease, it seems bilateral lung transplants tend to live longer than single lung transplants. So what's new in lung transplant? I think there is a lot of things that are happening that are kind of exciting. So there's a lot of different ways you can improve outcomes in interstitial lung transplant patients or interstitial lung disease patients. First, they need to survive the wait list, and so we'll talk about the new CAS scoring system. You can expand the donor pool and get people transplanted more quickly, and so EVLP or ex vivo lung perfusion is a way to do that. We'll talk about that. DCD donors also expand the donor pool. Use of ECMO has kept alive a number of patients that wouldn't have survived till transplant. We'll talk about that briefly. ECMO can also be used to help survive the perioperative period. And then we'll talk about long-term outcomes strategies to improve that, although there's been less success in that area. So the CAS is this composite allograft score, which has replaced the LAS as of March 9th, 2023, and it's a combined priority score for each offer. So every offer that a patient gets, it used to be that you got a single score that was dictated by your severity of illness, but now every single offer generates a little bit different score for each patient. And some changes between the LAS and the the CAS, there you can do ABO compatible. It used to be that patients, if they had an ABO identical offer, that they got priority, and then they kind of ran the whole list based on severity of illness. But now it goes by ABO compatibility. So you kind of run the list with all ABO compatible offers. Patients that are disadvantaged, which are type O blood types, because they can only take O's but not, AB blood types, get a higher score to sort of compensate for that difference in the way that the blood type allocation is done. They also take into consideration whether patients have antibodies that might pose a challenge to matching, so donor-specific antibodies that can lead to antibody-mediated rejection. And so there's ways to code out for those, and then scoring advantages if you have a number of antibodies that are problematic and would lead to less offers. PEDS also gets an advantage. Extremes of height, either really tall or really short, can get an advantage in terms of their score. And then they take into consideration travel and proximity efficiency as a way to sort of save costs and improve, potentially improve outcomes with shorter ischemic times for offers. I mentioned EVLP, and this is an example. This is, I believe, from the lung bioengineering website. But there's machines, there's several in the market. The United Therapeutics Lung Bioengineering's one. Transmedics is another company that has an ex vivo lung perfusion device. So it's a machine that you can hook the lungs from the donor to that can perfuse the lungs, usually with a solution that's kind of normothermic. And that can allow you to do things to the lung to improve the quality of the lung. So say the patient has atelectasis, you can give it positive pressure ventilation or do bronchoscopies. If you can give the patient antibiotics. And so sometimes you can rehab suboptimal lung offers and make them acceptable. And so this is something that Toronto's been doing for quite some time. It's caught on in US programs, and a lot of lungs that may not have been usable for donors have now been sort of resuscitated and can be used. And so it's a means of expanding the donor pool. And this can be combined, before I get to that, this is an experience with the ex vivo lung perfusion. This article says that it's associated with inferior outcomes after lung transplant, which you can see here. But in general, the clinical trial that's being done by lung bioengineering appears that outcomes are largely equivalent. And so I think it's something that's being used. I think in general, outcomes are overall the same, although this one article highlighted perhaps inferior outcomes. And so I think remains to be seen exactly whether that'll change the way that it's utilized. Another way that we can expand the donor pool is looking at donation after cardiac death. Most of our donors today come from deceased brain dead donors. So most patients overdose, have a stroke, have an intracranial hemorrhage, sometimes trauma are the ways that patients end up brain dead. But only about 20 to 40% of brain dead patients have acceptable lungs that go on to be utilized for lung transplantation. And there's a number of patients that may have irreversible brain damage, say after an anoxic injury. And these patients can have life support withdrawn and can be monitored. And if the patient expires in a reasonable time frame, usually less than 60 to 120 minutes, depending on the particular program's standards, they can be re-intubated and you can start organ harvest. There's also an option for something called normothermic regional perfusion, which is essentially like once the patient's re-intubated, you can put them on ECMO support and perfuse the organs and then harvest the organs and utilize them. And so there's a lot happening on sort of the donation front to expand the donor pool. There's some risk for aspiration and atelectasis, so you have to take that into consideration. And some programs will pair DCD donation with EVLP so they can have another look at the lungs before they commit their recipient to undergoing the surgery and accepting the lungs. But is an option to get more lungs for our patients that need them. This is an article from thoracic surgery clinics looking at donation after circulatory death and lung transplant, and the outcomes were largely equivalent. ECMO support can be used in a number of ways to help facilitate lung transplant. Preoperatively, you can use veno-venous ECMO in patients with advanced interstitial lung disease, and so we do this fairly frequently now. Many of these patients are very oxygen limited, and so you can get patients up and ambulating so that they don't go into surgery too deconditioned, or they're not considered sort of past the window where they're too sick for transplant. One article that I quoted there from many years ago quoted an 80% 6-month survival versus 50% with mechanical ventilation. I think most programs now forego mechanical ventilation without ECMO support and proceed with ECMO. If you get to the point where you need to be intubated and supported with mechanical ventilation, almost all patients that are viable lung transplant candidates will end up on ECMO. If patients have significant pulmonary hypertension or right heart failure, veno-arterial ECMO support's an option. You can also use ECMO as opposed to cardiopulmonary bypass intraoperatively. It's associated with decreased bleeding, need for transfusions, primary graft dysfunction, and renal failure. And then you can use it postoperatively to support your transplant patients if they have severe primary graft dysfunction, which is a complication where patients may have increased oxygen needs for, in that first 72 hours post-transplant. Or if they have significant pulmonary arterial hypertension, they tend to have significant hemodynamic swings, and also a lot of times the left ventricle can't accommodate the increases in preload you see after you reduce the pulmonary vascular resistance. And so you can use ECMO support to sort of allow the RV to recover, or the LV to accommodate that increased preload that it's going to see. And it can reduce some of that early post-operative morbidity that we were seeing in patients with substantial pulmonary hypertension. This is just another study looking at use of ECMO and mechanical ventilation, and you can see most patients getting ECMO support as opposed to isolated mechanical ventilation now. So usage at the time of this article had increased by 271%. So how do we improve outcomes? That's something that the lung transplant community has been struggling with. So survival's been stable despite older and sicker patients. So maybe we are doing a little bit better, and we're just more aggressive in who will transplant. Are other ways we might be able to get better outcomes? Improved immunosuppression, so you get less infections, perhaps less rejection with improvements in our practices for immunosuppression. Better means of detecting rejection, better treatment for rejection, and then developing an effective treatment for chronic lung allograft dysfunction, which many people kind of think of as chronic rejection, although it's more sort of lung failure over time, and it's not completely understood exactly why that happens. And so one article looked at use of sirolimus plus tacrolimus maintenance as compared to kind of standard tacrolimus and mycophenolate treatment, and found perhaps superior outcomes. So this might be something that in the future will translate to improved outcomes. There's new methods that are being used to earlier identify rejection. So cell-free DNA is a means of doing that. So you can with blood samples look for DNA from the allograft that's kind of floating free in the person's serum. And if you see elevations in the level, it's a marker that they have injury. And this would be, compared to our biopsying patients and trying to show histopathologic evidence of inflammation in blood vessels or airways. And so it may be an earlier means of detecting acute rejection, which would allow for earlier treatment and potentially reduce rates of CLAD. And then I think the future of lung transplant, number one, treat the diseases and avoid lung transplant altogether. So we've talked a lot today about improvements in treatment of lung disease. And so, if you can prevent patients from progressing to a point where they actually require a transplant, that's the ideal goal. Other things that we may see down the line, xenotransplantation. This has been tried with heart transplant in the not too distant past at University of Maryland with a pig heart that I believe they used. And then bioengineering of lungs, where they create a scaffold and then can use your own cells to build a lung is kind of the ultimate goal, because then patients wouldn't require, be your own cells, you wouldn't require immunosuppression for that. Switching gears a little bit, we'll talk about who and when to refer for lung transplant. And so this is a consensus document that the International Society of Heart and Lung Transplant released. And so there's, these are absolute contraindications to lung transplant. The boundaries for who is an acceptable lung transplant candidate, I think, changes all the time. The age limits have largely gone away. I think there's still kind of rough cutoffs where most programs aren't doing more older than 75, but we're much less focused on chronologic age, and we're focusing more on, how does the patient look, how do they function, how much longer can this patient live. There are still things like, active malignancies, recent malignancies, significant cardiac disease, liver disease, renal failure, and need for dialysis if you're not going to be a transplant candidate. Those are things that would prohibit transplant, but the bar seems to move all the time. These are things that are listed as higher, substantially increased risk. And I will say, every program is a little bit different in terms of the amount of risk that they're willing to take on in any individual candidate. And so I think, if and it varies, I think, depending on what's been going on with their program lately. And so I think it's never a good practice to just assume somebody's not a lung transplant candidate unless there's a very, very obvious contraindication, active lung cancer, things like that. It's always worth reaching out to a transplant candidate if a patient, or a transplant center if a patient's interested in pursuing transplant, just to find out. And again, and if patients are really interested in pursuing it and you think they might be reasonable and they were turned down by one center, it's never wrong to get a second opinion from another center that may be more aggressive. So things that I thought that were notable here, age 70 is a high risk thing. BMI, greater than 35 is sort of the absolute cutoff that we typically use now, but it's considered a substantially increased risk. So some centers may be willing to go above 35, particularly if a patient doesn't have central obesity. And then functional status is also, really a difficult thing to kind of pin down. We found this out with COVID. We were transplanting patients with severe ARDS off ventilators and rehabbing them, and so it is something that's modifiable potentially. When do you refer patients with interstitial lung disease? So, any patient that you're seeing at the time that you're seeing a patient with a UIP pattern or progression of a fibrotic ILD, I think it's reasonable to refer them to a transplant center. It gives that center time to evaluate the patient. It gives the patient increased time to learn about the transplant process and get all their testing done. And then it also, if you find some issue that may preclude transplant, it gives that center and that person time to work on that and potentially modify that issue. When do you move forward with listing? So if patients are showing an absolute decline in their forced vital capacity greater than 10%, that should get your attention, and many places will list. I think it depends. If you drop, from 90% FVC to 80%, we might hold off and continue to monitor closely. But these are what the guidelines show. And a decline in your DLCO greater than 10%, a decline greater than 5% in forced vital capacity with radiographic progression is another thing that could prompt listing. Desaturation on 6-minute walk testing is another criteria that they use. Or a 50% decline in your 6-minute walk distance, you would consider listing at that point. Again, probably earlier than our center would do it, but we usually wait till patients are on a little more oxygen, but at least trying to get them through the process. And then development of pulmonary hypertension. Dr. Nathan mentioned the significance in terms of morbidity and mortality with development of pulmonary hypertension and fibrotic interstitial lung disease. And so, that's definitely something you should be monitoring for and consider referral for transplant if you find it. Just in the interest of time, I'm going to move past this. This is a paper that we published looking at patients that were evaluated at PFF centers and found that maybe even in sort of pulmonary fibrosis foundation centers, there may be less aggressive listing of patients and referral for appropriate evaluation of lung transplant than there should be. This is a picture of the National Harbor Walk this year from our center. So that concludes my talk, and I'll turn it over to Dr. Meyer.
Thanks, Tricia. So yeah, thank you to the organizers for inviting me. Great to be back in person after, I think it was 2019, the last time we were all together. So yeah, when to refer for clinical trials and what's on the horizon. So I could make this short and say that you should refer patients for clinical trials at any point in their patient journey. But I'll perhaps take up my 15 minutes by going into a little bit more detail. So these are my disclosures. I apologize if I've left anyone off. This is what I'm going to do, talk about why we perform clinical trials, considerations for patients who might want to go into clinical trials, and then I've also been asked to tell you what the future holds for ILD treatments, so I'll try and squeeze all of that in quite quickly. So for those of you who are not familiar with the drug development process, essentially in developing a drug, one comes up with a great idea. You decide that pathway X is the most important pathway in the pathogenesis of IPF, and so you develop a drug that blocks that pathway. What you then do is go through the medicinal chemistry of finding a compound that will block the pathway. When you've done that, you do your preclinical experiments, often using cell culture and animals, to show that blocking pathway X has an antifibrotic effect. And if you still think you're on the right track, you then start doing safety studies in animals, where you give the drug to animals and make sure it doesn't unexpectedly kill them or anything. And then once you've done that, you start to think about introducing your drug into human beings. So there's already a lot that's been done in drug development before we get to human trials. But once we get to human trials, we divide those up into phases 1 through 4. And I'll just talk you through the different phases. But essentially, we start off very concerned about the safety of the drug, and safety remains an important consideration throughout the trial process. But as we get closer to drug approval, we also become very focused on efficacy. And for a drug to be approved, it ultimately has to be both safe and efficacious. And that's what we're trying to demonstrate as we take the drug through these various stages. So phase 1 trials, as I've already told you, done after the animal studies, they almost always involve healthy volunteers. So this is the very first time that your drug is being given to human beings, and the goal is to make sure it doesn't have any unexpected or very nasty side effects. It's also an opportunity to try and understand the dynamics of that drug in a human, so look at the pharmacokinetics, and if possible, also look at the pharmacodynamics. So pharmacokinetics was that boring thing at medical school where you have the different graphs looking at area under the curve and time to peak exposure, and that's when you learn about how your drug should be dosed. Pharmacodynamics is learning about whether the drug is actually engaging the target in the way you expected it to. So this all tends to be done in phase 1 trials. They tend to start off with single ascending dose, so you give the healthy volunteers just a single dose of the drug, and if all goes well, you then start giving healthy volunteers multiple doses of the drugs. And as I've told you, this is the goal. And so this is normally relatively straightforward, but occasionally things get exciting. This is an example of a phase 1 trial that went badly wrong. This led to changes in the way we do phase 1 trials in actual fact. So they came up with this anti-CD28 monoclonal antibody, thought it was going to be great for treating autoimmune diseases. They lined up 8 healthy volunteers and gave them all the drug at the same time in different doses, and 2 of these 8 healthy volunteers had placebo. Unfortunately, the drug led to this catastrophic cytokine storm. So the patients started dropping they were given the drug at 10-minute intervals. So the first patient became very unwell, and then the next one became very unwell. And the poor individual at the end of the line could see what was coming to him unless he had placebo. But this is why we do the phase 1 studies, is to make sure there aren't unexpected adverse events. Nowadays, you would never dose all of the volunteers at the same time. You would wait until the first one tolerated it well before you moved on. But anyway, these are phase 1 trials, so these are not really relevant for our patients. Phase 2 trials are when you go into your patients with disease, and this is when you start to see if the drug is doing what you expect it to, i.e., does it have an antifibrotic effect? Phase 2 tends to be divided into A and B. A tend to be short trials, often where you use biomarkers as a way of telling whether the drug works. Phase 2B tends to look more like a phase 3 study, so these are longer trials, and where in IPF you would tend to use forced vital capacity as the primary endpoint of choice. I'll show you some examples of both sorts of studies, but again, these are important considerations for patients. So phase 2 trials are really the first time where we're testing to see if a drug might work in the way we expect it to. There's actually very little benefit to the individual patient for going into these trials. We're essentially asking patients for their goodwill to volunteer to be guinea pigs to see if this drug works in the way it might, but they're never going to get benefit from it. Phase 2B studies are longer. We've already done phase 2A studies, so we have a better indication the drug works. By the time you get to phase 2B and phase 3, there is more potential that the patient will gain advantage from being in these trials. And it's often important to make sure patients understand this difference between the trial stages, because you're asking of them different things. So this is an example of a phase 2A study that we did with a PI3 kinase inhibitor. Essentially, we asked patients to take the drug for between 7 to 10 days. They had a bronchoscopy and a PET scan, both at baseline and end of study. This was a very intensive study for patients. And really, as I said, the patients are just volunteering for the greater good. They're doing this so that we can see whether the drug works, but they personally didn't get any therapeutic benefit from being in the trial. Phase 2B trial, by contrast, this was the Tomorrow study, which was the first trial with nintedanib. This was a 52-week study. There were several different doses looked at. The primary endpoint was FVC. In this trial, patients had the option to go on to open label treatment at the end. And so patients had the potential to go on to an effective therapy well in advance of it being available in the clinic. So by the time you get to this sort of study, there is potential benefit for patients in that it might help slow or prevent decline in their forced vital capacity. And then phase 3 trials are really done to prove to the registration agencies that you have a drug that is safe and effective. So these are the heavily regulated studies. The FDA and other agencies have a lot of input on the way the study is designed. And at the end of these trials, you're hoping that you're going to get approval for this drug to be used in clinical practice. So these tend to be longer and larger, so much bigger studies. For example, current IPF phase 3 studies are including about 1,000 patients, and they're running for a minimum of 52 weeks. The regulatory agencies request that there are 2 trials done, so there tend to be paired trials. In general, the regulatory agencies won't approve a drug just off one study alone. And obviously in IPF, we have the examples of the pirfenidone and nintedanib trial programs. Again, these were 52-week studies run with several hundred patients in each arm. And as we know, both drugs got approved off the back of these. So what do patients need to think about? Well, virtually every trial is placebo-controlled. So patients need to know there's a chance on no treatment. That's often seen as a bad thing, but there are plenty of examples in the IPF trial literature of where it was better to be on the placebo than it was to be on the active treatment. So it's not always a bad thing to be on placebo. Patients need to know that these are time intensive. So this is an example of the schematic of the Isabella trials that were recently reported as negative. But this is a sort of example of a phase 3 program. And sort of each line here is a study visit. So over 52 weeks, patients are expected to come up to the study center somewhere between 9 and 15 times, depending on the intensity of the study. So it does require a time commitment by patients. Sometimes there are open label studies, so particularly with the phase 3 study, what will happen at the end of 52 weeks is that the patients get the option to go on the study drug. So this is a potential benefit. If the drug is effective, they're getting access to drug ahead of approval. There are important steps taken to make sure trials are safe. As I've just told you, some of the trials have actually shown harm of active treatment. So there tends to be a lot of effort put into ensuring patient safety, both at the local level and sort of internationally for these multi-center trials. And we have various levels of things going on to ensure safety, including an independent data safety monitoring committee. And there are examples of studies that have been halted because the Data Safety Monitoring Committee have felt that the study drug was no longer safe to be administering to patients. And what about the challenges of running trials? Well, this was my trial team back in London. I only put the picture up not to scare you, but just to show how many people tend to be involved in delivering clinical trials. It's no small undertaking. You need study nurses, study coordinators, you need people to book the patients and the tests. For the early phase trials, you need lab staff to be able to do a lot of the work with the samples. So it's no small undertaking to run trials, which is why they tend to be run by bigger centers and why I think it's important that we have this flow of patients from the community to bigger centers so that they can participate in trials. You know, I've just given here some indication of how big the trials are. Phase 3 trials are now including up to 400 sites for each study, so they're enormous undertakings, and they cost the pharmaceutical companies an awful lot of money to deliver. So these are big efforts, and I think it's important as a community that we are working hard to sort of streamline this and get our patients into the studies. So to answer the question that was posed in my talk title, when to refer, as I told you, anytime. Certainly when I've recruited to trials for those early phase 2A studies where the patient doesn't really get any benefit, I tend to recruit from my newly diagnosed patients, often before they've started pirfenidone or nintedanib. So that very early visit, when you make the diagnosis, patients are often most motivated to do things for the greater good, in my experience. By the time patients have had the disease for 3 years and have seen inexorable decline, they tend to want to be in studies where there's a bigger chance of success. So patients with more established disease who are on antifibrotic therapy tend to be better candidates for the phase 2B and phase 3 clinical trials. Similarly, if you've got patients who've been intolerant of antifibrotic drugs and are therefore not on any treatment for their pulmonary fibrosis, they are very good candidates to be in clinical trials because ultimately they have very little to lose because they don't actually have any treatment to prevent their disease deteriorating. And increasingly, we're also doing trials to look at disease complications, so treatment of PH-ILD, treatment of cough as a symptom. And again, I think important to think about these as possible reasons to be referring your patients for clinical trials. And then very, very quickly, in a few minutes, I'm just going to talk about the ILD treatment horizon. This slide is always out of date when I use it. I try and keep it up to date, and I always miss one or two things, and then people come up and tell me off afterwards for not including their favorite drug. And we're lucky in IPF, lucky and unlucky. IPF is a very complex disease. The pathogenesis is complicated. There are probably 100, 150, 200 different molecules that you could target in the fibrotic cascade and plausibly have an antifibrotic effect. And so what you see if you look across the whole development pathway for IPF is that there are a lot of very different approaches being taken. And I've tried to summarize some of these here, and I've tried to summarize them based on the different components of IPF pathogenesis. But you have drugs that target the injury to the lung. You have drugs that target sort of epithelial turnover. You have drugs that target the fibroblast to try and prevent production of collagen, and we increasingly also have drugs that target the endothelium. And so there's lots of different ways it would seem to target IPF. The drugs in bold, or the names in bold, are the ones that are most advanced in clinical trials. And then, as I've also mentioned, there's an increasing approach to treat symptoms. So we're not just treating the disease, we're treating the things that impact patients' quality of life. There is evidence, just using pirfenidone and nintedanib, that combination treatment is probably better than single treatment alone. But as everyone who's used pirfenidone and nintedanib knows, the two drugs don't go very well together because of the overlapping GI side effects. But I think all of us expect that the future will be of combination treatment. And I apologize to company representatives in this meeting whose drugs I'm not going to mention. I'm just really sticking with those that are in phase 3. But these are drugs that are currently running through phase 3 trial programs. So inhaled treprostinil, approved for PH-ILD, but in the same study showed an apparent effect on FVC. So there's a trial going on to see if this effect is genuine, and to see whether treprostinil has a disease-modifying effect in IPF as well as an effect on pH. There's Boehringer's PDE4 inhibitor, so in phase 2 trials, over 3 months, this showed an effect in stabilizing disease over that 3-month period. So there are 2 parallel phase 3 studies, both in IPF and progressive pulmonary fibrosis, that have both now recruited looking at this PDE4 inhibitor. There's Pliant's alpha V beta-6 inhibitor that's just entering a phase 2b/3 program. Again, they did 3-month studies looking at different doses of the drug, showing that their drug, again, appeared to prevent decline over a 3-month period. So they're just starting in phase 3. And this is a BMS drug looking at LPA receptor 1 inhibition, and again, they've just started a phase 3 program looking at patients with both IPF and progressive pulmonary fibrosis. And I haven't included them on here, but there are other programs ongoing looking at inhaled versions of the existing antifibrotic drugs, so both inhaled pirfenidone, inhaled nintedanib. There's also a program looking at a deuterated version of pirfenidone with the goal that that may cause fewer side effects than pirfenidone itself. And then we've also, as I've said and keep reiterating, been looking at treatment of treatment of symptoms, and so this is an opiate agonist-antagonist that has been shown to be effective in phase 2 trials in the management of IPF cough, and this is going into longer studies in phase 3, again, to see if there is a sustained benefit on cough in IPF. So that's a very quick whistle-stop tour. So my conclusions, I think clinical trials are crucial in the care of our patients with IPF. We have to look at how successful the oncologists have been. The oncologists try and enroll all of their patients into clinical trials, and I would love to have a future where we try and do that with all of our IPF and other pulmonary fibrosis patients. I've told you a little bit about the different phases of trials, and so that may be an important consideration for patients when thinking about trials. I've also told you that the patient's stage of disease and the complications and symptoms they have may also influence the trials that they're interested in. I've shown you that there's a lot of drugs in development, both in phase 2 and phase 3. And I've also kept reiterating this importance of treating symptoms. So I'll stop there, and thank you very much.
Thank you, Tim.
So I have no disclosures, and we're going to get right on to the objectives for today, perhaps. So we all know, and I'm not telling you anything new, that IPFs and other PPFs are associated with a shortened lifespan, an unpredictable disease course, tremendous symptom burden, impact on caregivers, the need for supplemental oxygen, and the need for palliative care. And these are just some of the references. By no means is this an exhaustive list, but the overall is that these patients experience a poor quality of life. So I'm going to go through a few quick literature search. So palliative care needs were reviewed in 37 manuscripts of patients with ILD. We all know that the course of ILD is unpredictable. So what happens is this leads to prognostic paralysis on part of the care provider or the healthcare professional. And we know that hospitalized patients have higher symptom burden and higher mortality. And there are barriers that exist about meeting palliative care needs. The takeaway from this particular manuscript was that palliative care should be incorporated as part of the MDD for all ILD patients. In this study sponsored by the Pulmonary Fibrosis Foundation, they surveyed clinicians at 68 PFF care center networks. And most providers exhibit a knowledge of palliative care and agree for patients with that it's important for patients with ILD, but were unsure of when the optimal timing was. In this study, we took a look at unmet needs of caregivers of patients with PF because we know the impact on caregivers. And most of the caregivers are 50 years and above and often face their own morbidities. And in surveys and focus groups with patients, most caregivers perceive themselves as invisible at the visit. They reported that when the physician or the APP came into the room, no one addressed them. And so they feel invisible. The other part is they said that often the patient doesn't realize that this person is their caregiver. Oh no, that's just my wife or that's my husband. So we'll talk a little bit about how you can approach this, but both patients and caregivers want to be engaged early and better supported throughout the disease trajectory, if I could speak. So a program was done at UCSF where they did palliative care and ILD collaborative. And so the ILD program paired with telehealth delivery of palliative care. And overall, they found that all patients and caregivers interviewed agreed that palliative care was very beneficial. So what is palliative care? This is probably one of the most confusing terms. No, it's not the end of life. So palliative care is a specialized medical health care for patients that are diagnosed and living with a serious illness. So that's the takeaway, that serious illness for any patient. So it could be heart failure, it could be cancer, it could be chronic kidney disease. And what palliative care is, we describe it as an extra layer of support. The care is focused on providing relief for the symptoms, suffering, and the stress of the illness. And the goal is to improve quality of life for both the patient and the family. And it's based upon the patient's needs, not upon the patient's prognosis. And it's appropriate at any age and any stage in a serious illness. And most importantly, it can be provided along with curative treatments, such as being on antifibrotics, being evaluated for lung transplant. So why is it important? In oncology, previous research studies have shown that patients who participated in palliative care had fewer symptoms, they had a better quality of life, and they lived longer. So in this schema, palliative care is appropriate at any point in a serious illness. So let's just walk through this quickly. So on the left, you see the diagnosis throughout the course of the illness, and you see that the pattern of palliative care is wavy, and that illustrates what's happening in the disease. So palliative care can be offered alongside these disease-directed therapies. Really, the whole goal is that we want to address the symptoms that our patients experience, and we know that our patients have a vast amount of symptoms. The impact in this patient and family impact shows that you have an improved quality of life and symptom burden for the patients, and it reduces symptom distress by 66%, and this drives a high patient satisfaction. In the system impact of palliative care, it reduces avoidable spending and utilization in all settings, from readmissions to emergency visits to hospital visits, and overall decreasing total cost of health care. The difference between hospice and palliative care. So palliative care should be offered at the time of diagnosis of any serious illness and thought of as an extra layer of support. Whereas hospice, most people don't receive hospice until the final weeks or even days of life, possibly missing out on months of helpful care and quality of time. Q, Jimmy Carter. Think of Jimmy Carter and his experience in hospice. And he's living 7 months later, and he's having a pretty reasonable quality of life. So, step on the gas, and we're going to shift gears for a minute. The messaging we've been doing, it's not working. So about 3/4 of Americans don't know what palliative care is. Only 1/3 of Americans have advanced directives, and this hasn't changed much even in the face of COVID. Why? Because misconceptions are rampant. When people hear the term palliative care, they're like, no, I don't need that, or the provider might say, no, my patient doesn't qualify. So there's a lot of misconceptions, and our language isn't clear. Yet, when patients and the public hear stories of successful palliative care, they want to know more about it. So what's happening is there's now, maybe, the new language is serious illness. So serious illness is a health condition that carries a high risk of mortality and either negatively impacts a patient's daily functioning or quality of life and excessively strains or impacts his or her caregivers. Think of IPF, PPF. So there's this surprise question, and many of you may use this in your practice. Many of you may not be aware of it, but the idea is you need to step back and think, would I be surprised if this patient was alive in 1 year? So this new serious illness messaging campaign, if you Google this, it's out of the University of Washington, and there's language, and they've done focus groups with patients and care providers, and this is probably going into its 3rd year. So they have evidence-based messaging for serious illness care. And we'll go through a few of the things. So there's 5 principles. 1, when you're with your patient, talk up the benefits. Present choices for every step. Use positive stories. Invite dialogue and not just once. And invoke a new team. So the new team, it's interesting who the people that can be on this team. It can be the social worker. You can bring in specialty palliative care. The examples that they give, you can even bring in their clergy, Meals on Wheels. So people who know them, it's about talking to these people with serious illness and having them understand that there are ways for them to have a better quality of life. Now the challenge is, and I know many of you are probably sitting there thinking like, I have 20 minutes to see this patient. And we're trying to figure out what's wrong with the patient and how we treat them. This is a sensitive conversation. And how do I do this with time? So we encourage this, and this is a resource that everyone should be aware of. It's called getpalliativecare.org. And this is hosted by the Center to Advance Palliative Care out of Mount Sinai in New York City. So I know this isn't so clear, but what you do here is, as a patient, they can do it, or as a healthcare professional, you can do it. You enter the patient's address and their zip code or city or state. And what this does is it takes you to that locale, and it tells you if there's hospital-based, there's nursing home, office clinic, home or home-based palliative care. So these are resources. I have one quick story. Somebody reached out to me and said, I live in Louisiana. My doctor, I asked him about palliative care. He said, we don't have that around here. And I said, well, what's your zip code? We put in the zip code, and there were 6 providers around the 30-mile radius. So this is an excellent resource, and this is hosted by the Center to Advance Palliative Care. So 4 takeaway messages for you today. Address the caregiver when you're in the room and ask them if they know they're the caregiver. They are a critical part of the team, and they do so much for these patients. Utilize the surprise question. Would you be surprised in a year if this patient is alive? Ask these questions, and this is from the healthcare professional to the patient. What's important to you, and what do you see in your future? And another aspect or another way to ask that is, what keeps you up at night? So this is addresses the patient's worries and concerns. And then remember the resource, getpalliativecare.org. And lastly, some resources. The Pulmonary Fibrosis Foundation has provider and patient position statements on palliative care, and the American Thoracic Society recently released priorities for a joint ATS policy statement on palliative care. And I forgot to include, but there's also a new statement from the European Respiratory Society. So thank you.
I wear a hat with the PFF, and we've spent a lot of time putting this program together, and it's just amazing seeing everybody here, hearing all the discussion. So thank you for being here. So what I'd like to do in about the next 10 minutes is tell you about the Care Center Network and how you can collaborate with the Care Center Network site. And I do apologize, after I finish talking, I'm actually going to leave because I have to be at a session next door. All right, here are my disclosures. I do work with a number of pharmaceutical companies in clinical trials and research. So I wanted to just start off by talking about the Pulmonary Fibrosis Foundation. Obviously, you're all here because this is the PFF, but it may be that you haven't really thought about what it is that the PFF is here for, and really the foundation itself is to mobilize people and resources to provide access to high-quality care and lead research for a cure so people with pulmonary fibrosis will live longer and healthier. And as one of the key components of the Pulmonary Fibrosis Foundation, the Care Center Network, or CCN, is really essentially an outreach organization. Its mission is to propel the field of PF through optimizing diagnosis, patient-centered care, education, and research. And this is done really at a local level, because what we really try to do is bring what the Pulmonary Fibrosis Foundation does centrally to many different locations across the U.S. Our vision is that every patient will receive a prompt, accurate diagnosis and receive the highest quality patient-centered care. And so what I'd like to do in the next couple of slides is just really tell you about the Care Center Network. This is a group of 81 sites, and we've recently added 7 clinical associates across the U.S. to try to improve the lives of our patients with pulmonary fibrosis. And all of our centers have groups that have expertise in treating adult patients with fibrotic lung disease. And sort of essential to this is what you heard a lot about this morning, is this multidisciplinary diagnostic approach. And our goal is not just to provide patient care at an individual level, but to do pulmonary patient-oriented research and work with the PFF to provide educational material and advocate for our patients. So we really see this as being centered around our patient in the middle. There's the Pulmonary Fibrosis Foundation, which is essentially a central organization. And then there are the pulmonary fibrosis community itself, and then there is our Care Center Network, which is made up of the care centers and our clinical associate sites. Now, we're really excited about this because what we'd like to think of is that this is essentially a hub and spoke model, that we have something that is central in the Pulmonary Fibrosis Foundation, that we're generating a number of products, which I'm going to tell you about, and that we disseminate through our Care Center Network, including our clinical associate sites, and that those then reach out to all of our community providers and our patients in the community, because the whole goal of this is really to serve as a resource for all of the patients with PF in the U.S., not just those who are cared for at Care Center Network sites. So as I mentioned, you know, this is really a pretty exciting year for us. This is our 10th anniversary of the Care Center Network, and for those of us who were around 10 years ago, we will remember that there was a time where people said, you know, you can't really even do clinical trials in pulmonary fibrosis because there aren't enough patients and none of the sites will work together. And now 10 years later and 81 sites further down the line, we recognize that those were really just misinformed people and that we've really made a tremendous amount of progress in that last decade. So just congratulations to all of us on reaching our 10th anniversary. I especially want to point out the expansion this year to our clinical associate sites. These are often sites that are at that are in the community or that have not had as much infrastructure as some of our Care Center Network sites. And we're really excited because we've extended our reach into 3 additional states. So you can see the names of our sites, and each one of our clinical associates has a partner within the Care Center Network to serve in terms of a resource for MDD if their own site does not have one, although all of these sites do have them, to help with referrals for lung transplant and for research collaborations, particularly around clinical trials. We're really delighted that we were able to add Maine, South Dakota, and New Mexico to our extension of our Care Center Network family. So a very exciting year for us. So, you know, when we talk about what our goals are, we really have 4 pillars that we kind of work around. The first is to improve the diagnostic process. You heard a lot about this morning. I think that you could say that one of the themes that everybody brought is how important it is to have the correct diagnosis. Everything else flows from that. We want to enhance the quality of care. We have a number of programs that are around improving and identifying process that will allow improvement of quality of care. We definitely want to accelerate research. We do this both by research which is from within the Pulmonary Fibrosis Foundation and the Care Center Network, but also by catalyzing research that's going on outside, including collaborations with the NIH, which you'll hear more about from Kevin. And then last but not least is that we really must serve as advocates for the needs of the PF community. You know, again, there's been a sense that this is a very rare disease, and I think that all of us who care for this patient population recognize that it may not be quite as rare as we think, but it is a community that requires a lot of additional resources. So how can you get involved? How can you collaborate with the Care Center Network if you're not currently in a Care Center Network site? Well, we'd like you to do lots of things with us. So firstly, thank you for being here with us at our 2023 Biennial Summit. Our next one is in Chicago in 2025. We have lots and lots of educational material that we would love to share with you. All of this is available freely on our website. You can also get it in print if you prefer to have it in that fashion. Many of our statements, particularly our patient education materials, are available in both Spanish and English if you have a Spanish-speaking population. We would love for you to join us for our web-based journal clubs. These happen about once a month or every other month. Some of them are run by the Care Center Network. Some of them are by our wonderful Nurse and Allied Health Network. And there are always research opportunities for patients. You're going to hear a lot more from Kevin about the community registry, but I also really want to call out the fact that the PFF has invested a lot of energy into building out a PFF clinical trials finder. We recognize it is difficult for patients to understand which trials they might be eligible for, and so we've really tried to build an interface that makes this much more obvious and will also allow patients to assess whether the trials are being run in areas that are near them. So it allows them to identify both something which is diagnosis appropriate and also regionally appropriate. So please use all of these resources, and if there are things that you don't see that you think would be helpful for you in your daily practice, things that we can offer to you as providers or to your patients, please let us know because we are constantly building new resources. I do want to let you know that we have an upcoming journal club, which will be on January 10th. We would love for you to join that. I believe Deji is going to be talking about one of his papers. And with that, I am going to stop and say thank you very much for being here, and I look forward to seeing many of you over the course of the next couple of days at the summit. Thanks.
Thanks so much. Thanks for letting me be here. It's great to see you all. And it is really an honor for me to be able to tell you about one of the key projects that the foundation has been involved in over the past, well, I started thinking about it about 10 years ago, and that's the registry. And so I want to tell you kind of where we are, but also how you can use the registry and how you can help the registry move forward. These are my disclosures, which really involve working with various companies to talk about studying different types of interstitial lung disease, trying to find new therapies. So I've been lucky enough to be the chair of the steering committee for the registry since it started a little over 5 years ago, but all the heavy lifting comes from the foundation. So Misha Cadet, shown here, is the project manager, so she does all the work, and then I get to come up here and tell you all about it. So you heard from Toby earlier about clinical trials. Critically important. It's a way we test a drug, see if it works. But that clinical trial has a very narrow population. There's pages of inclusion and exclusion criteria. And we often sit back and read a journal article and say, well, how generalizable is that to my patient? You know, would they have fit into the study? And if they don't, would they benefit from this? So registries are a different type of study that can help us answer some of those questions. In a registry, the data that are collected more naturalistically. So instead of a clinical trial protocol, where every 3 months you come in and get this documented test, and you must come in within 7 days on either side of that 3-month interval, or it's a protocol violation, registries say, we want the data, give us the data, but just give us what you did. So you can collect things around care patterns. How often did people come in? How often did they get a pulmonary function study? Registries can be designed or redesigned or amended for specific purposes. What are the questions that you're trying to ask with the registry? In terms of the Pulmonary Fibrosis Foundation, there's 2 databases. So we started the registry back in 2016. That's when the first patient was enrolled. That was a very traditional center-based registry. Care center networks could go to a subject, give them an informed consent document. At the center, the study coordinators would enter data from the medical record every 6 months and do that throughout the registry for the people that were enrolled. We were able to collect CT scans, and if patients were willing, we could get blood samples. I'll tell you more a little bit down the road, but we changed that in July of 2022 to more of a patient-entered, what we're calling a community registry. And I'll tell you more about that in just a few minutes and how that works and why we did that. Sonia talked about, the mission of the Pulmonary Fibrosis Foundation, and the registry is part of that mission. At the center of that are the patients, right? We want to improve the care of patients, improve the quality of life and quantity of life for patients with interstitial lung disease. And that can be through research, that can be through understanding practice patterns, that can be through advocacy, better oxygen therapy be an example, or community outreach, or back and forth with the community. And the Care Center Network and the registry, a part of that, are really key to these different aims. People often look at the Cystic Fibrosis Foundation registry and say, man, look at that registry. It's like a flagship, and no doubt about it, it is. But what you don't realize, or what I didn't realize until I read this paper a number of years ago, is how long that process took. All right? It started in the 1960s, and you can't see well on this slide, but it evolved over time. It went from paper forms to electronic forms. The type of data that were entered became more rigorous and adapted. So it grew over time and adapted, but it took a lot of time to get to where it is today. So our registry, which I'm extremely proud of, has a similar timeline, although it's much shorter. So our first patient was, well, as Sunny said, the Care Center started around 10 years ago, and it was really at the inception of that we started thinking about the registry, planning for it, and it wasn't until 2016 that we actually had a protocol, IRB approved, and we enrolled the first subject. The plan was to enroll 2,000 subjects, and we did that in just over a year. In fact, we had to put up brakes on some centers because they were over, just tons of people coming in, and there was way more need, or more interest, I should say, than ability for us to capture those patients. But we had a budget for 2,000 patients, and we could follow them for 5 years, and that's what we did. And as we followed those patients over time and the data became more rich, then people could reach into the registry and start doing research studies. So first we saw some abstracts, more recently publications, and more recently, lots of publications are starting to come out of the registry. And that's just really within a 5 or 6 year period. So that's how we started, a center-based registry with resources to cover 2,000 subjects. We collected a lot of clinical data. So you can actually go to the website and see what the forms are, see all the different data elements that were collected. But a lot of clinical data, the demographics, what medicines are you on, the diagnoses, your comorbidities, are you on oxygen, what are your pulmonary function studies, et cetera. We asked the centers to give us the CT scan that was closest to the time of enrollment, so maybe that was a few months before they enrolled in the registry, and then 2 subsequent CT scans. So we have a CT database of thousands of CT scans that can be used for research and are being used for research. We got some patient-reported outcomes. We used the short form questionnaire, a dyspnea scale, cough scale, and a fatigue scale. And then we collected big medical events, hospitalizations. Did you get a lung transplant? Did you succumb to your illness? And then about 9 out of 10 patients put their arm out and said, yeah, you can take a blood sample. So we got a biorepository that collected DNA, RNA, plasma, and serum from our patients at baseline or at the time that they were enrolled in the registry. It probably would have been higher than 90%. A lot of times, the reason people didn't do it was just logistics. I got to get home. I don't have time to say and get a blood draw or something of that nature. So really rich clinical, radiographic, patient-reported outcome complemented by a biorepository. The registry database for this first 2,000 patients, we closed it last fall. So there's no new data flowing into this registry, but those data are still there. And you can just see over that relatively short period of years how much data was there. So just under 3,000 CT scans. Pulmonary function studies, almost 15,000 FVC measurements. So tons and tons of data are just sitting there and available for utilization. Who was in the registry? By definition, we protocolized the registry to have 60% of patients with idiopathic pulmonary fibrosis. We didn't have to do strict things to change that, but the reason we did that is this was starting very shortly after we had the approval of pirfenidone and nintedanib. And we knew how those drugs behaved from clinical trials, but we didn't know how they behaved in the real world. So we wanted to have a significant portion of this registry be IPF so we could kind of understand perhaps one question, how does antifibrotic use work in a registry? Does it work like it in the clinical trials? So that's why we targeted 60%. As we move forward, and I'll tell you about the community registry, there are no more targets of different types of diseases. But about 60% were IPF, and then others were connective tissue disease, hypersensitivity pneumonia, other types of interstitial lung disease. As we learned from the first version of the registry, the center-based, there were lots of things that we said, well, how can we do this better, right? How can we slope up as we evolve over time? Well, we knew there were a lot of patients that wanted to be in the registry, and we couldn't. We didn't have a budget. So how could we increase participation? And borrowing from Kathy's talk in the last session, what about not just patients, but how can we capture information about caregivers, lung transplant recipients because of their fibrotic lung disease, or family members? So broaden the scope of the registry. In the first version of the registry, each center had its own IRB. Okay, that's how we designed it. We didn't have a central IRB. Central IRBs were just starting to come about around that time. So every center had its own IRB, which made it really, really hard to do amendments or to reach back out to subjects. As a foundation level, we didn't have the ability to say, we want to reach out with this questionnaire to everybody in the registry. To do that, we had to go to every center and say, put in this amendment through your IRB and get permission for you to reach out. It just was infeasible. So it was a limitation, and we said, as we move forward, we want the ability, if patients give us permission, to interact with them. We want to increase the flexibility. So now we have a central IRB, so we have one application that can go in and make amendments. We want to send out this questionnaire to people. We want to collect this type of information. One amendment, boom, disseminated, we can have the data. We want to minimize site burden, right? Particularly coming through the pandemic, and everyone's overwhelmed with work, having someone at the site enter all the data, a study coordinator, is expensive and time-consuming, and it's a burden to the site. So by moving that to the interested subject that can enter it on their own would decrease site burden. And then we wanted to increase utilization and pace. So that led us to what we're calling now our current project, which is the community registry. Again, there's the 2,000 subjects, that database is still there. Subjects that were in that registry can also be in the community registry. But the community registry is really a direct to subject, caregiver, lung transplant recipient, or family member registry. How does it work? Well, what I'd like all of you to do is when you go back home, print out information on this community registry and do what I do when I see my patients, hand it to them. Tell them about this community registry. All they have to do is go to the website, which is on these handouts that you can print off from the foundation, and go to pffregistry.org, and they sign up. There's an online consent that describes the registry, the protocol, the data securities. This is the same type of data security in terms of like an electronic medical record. So it meets all of the guidelines around confidentiality and data security for, well, again, anybody can hack anything, right? But it's the best that we have today. The patient then can sign up, do the consent. As part of that consent, they can say, yes, I would give you permission. I would like to be contacted about future studies. So we could help recruit for clinical trials. We could send out questionnaires that we're interested in getting data about. Boy, we want to work on oxygen advocacy. Let's ask people questions about their oxygen use or not use so we have data that we can better understand that problem. The types of data that we have, again, we've broadened the scope, so it's not just patients, but it can also be caregivers, family members, and lung transplant recipients, demographics, clinical information, slightly tweaked the patient-reported outcomes. In terms of the patient-reported outcomes, they're different between patients versus caregivers. And caregivers, we actually have a caregiver questionnaire about the caregiving burden on how that impacts caregivers' quality of life. Where are we? So these are data I pulled just from November 2nd, so last week when I was putting these final slides together. So this community-based registry opened in July of 22, so we're just over a year. We have almost 1,800 individuals that have joined the community registry. 67% are patients. 80 of those patients are lung transplant recipients. 25% are family members, 18% are caregivers, and we almost have 100% of the states represented. This is from what we call the dashboard, where you can kind of click on things and see different fields, but it just shows the pace of enrollment from where we started. So pretty much of a trajectory, maybe a little bit slower now, but we want to hopefully after this summit get a nice uptick as people have more interest or more information about how to enroll and participate in this. This is a busy slide, but it just highlights some of the very high-level things that we can get out of this. And I'm only going to highlight, to me, when I looked at this, something that was really, really disturbing. And that's on the top left. That top left box there says patient knows their diagnosis. 20% said no. And I'm like thinking to myself, okay, 1 of the 5 people that I'm working with in clinic leave my office, sit down in their car and say, I have no idea what he just said. I have no idea what I have. Not surprising and not surprising, right? I mean, we know that these types of things happen, but by looking at this now, we can say that's a problem. How can we address that? How can we improve our diagnostic communication with our patients and their caregivers so they know what's going on? So there are recruitment materials. You can just go to the PFF registry website. These flyers you can download. They give some very high-level information about the registry, and the link to the registry to sign up is right there. I have a stack of these sitting next to me every week in clinic. They go with me, every patient, and then now I have a dot phrase on my notes for them that if I gave it to them or not. So I remember next time when I come in, I can say, hey, I gave that to you last time. Did you fill it out? And they're like, oh, I did. And I'm like, here's another one. Next time, maybe you will. Or I did. I'm in it. Now I'm getting my 6-month follow-up. So it's super easy, and I think we can just have, one of the big goals was to have this broaden out, to increase the diversity in the registry. Those first 2,000 patients were patients that had means, geographically or financially or whatever, to get to a care center, be seen at a specialty center, and get enrolled in a registry. So talk about clinical trial bias. Well, there's probably a registry bias as well. Now it could be anywhere. I mean, I think there's still going to be limitations, right? Access to the internet in rural areas. There's still going to be limitations, but I think this is the next step in how we can broaden out the scope and diversity of the registry. There's lots of unanswered questions. I'm not going to read through all these. You could come up with 15 more on your own, I'm sure. But with your help with these registries, we can answer them. You can utilize this for research as well. So you have looked at these things, or you say, I have a question, I might be able to get that answer through the registry. You can, again, go to the registry website, click on a link, put in a brief proposal that gets reviewed, feedback goes back and forth, and you can get assistance with data analysis and move that question forward. And that's what's happening. This is just had a fun time doing this last week, just finding papers that had been published from the registry. This is not anywhere near a comprehensive list, but you can see it's working. The registry collected data, kind of like Field of Dreams. Build it and they will come. So data were collected, CTs, biospecimens, and now people are utilizing that to try to do research to improve the lives of patients with pulmonary fibrosis. So I will stop there. I'm supposed to be giving a talk at 3 at some rooms down the road, but they're switching the order. So I do have a few minutes for questions that I could try to answer from Sonia's talk on the Care Center Network, or if you have questions about the registry. Again, thank you guys for being here, and look forward to seeing you around the next few days.
Thank you very much. It's a pleasure to be here with everyone. So we'll switch gears a little bit and talk about a couple of interesting cases from our everyday practice and highlight some of the issues that we come across in multidisciplinary discussion, and often there are diverging opinions. So hopefully we'll get to see some of that. We had 4 cases ready, although we're reaching a little bit on time, so it might be 3 cases and maybe a bonus if we go through things quickly. It's really too bad because the 4th case was going to have the answers to everything, but we'll have to wait for that one for next year. So I'm really delighted to be up here with 3 of my colleagues, with Dr. Carrie Aronson from Cornell, with Dr. Amanda Grant-Orser from the University of Calgary, and with Dr. Lee Manouk from the University of British Columbia, who are really stars and rising stars in the field clinically and from a research perspective. So they've dug deep in their caseload and have 3 cases for us that will be certainly interesting to discuss. We're happy to take questions and, of course, be interactive and involve the audience, preferably maybe at the end of each case, just to ensure that we do end up finishing somewhat close to 4 p.m., simply because we can probably end up talking about this for hours and hours. So without further ado, I think we can start with Dr. Lee Manouk.
So I'm not sure whether it would be easier for, if there's an AV person around, to just switch to case number 2, the header slide, as opposed to me awkwardly flipping through a number of other slides, because we skipped through case 1. Don't look in case we do have time for case 1. Cover your eyes. Oh, there we are. Okay, case 2. Thanks everybody for being here. At the end of the day, you've toughed it out, and afterwards you can go and have a cocktail by the pool. We're almost there. So case 2 here. This was a patient, 41-year-old woman who presented with mild shortness of breath on exertion. She initially presented in early 2021, and she had a brief cough, and that got better, but then the shortness of breath wasn't getting better. And she had a CT scan that showed fibrotic lung disease, or was reported as such. She was trialed on prednisone 30 milligrams a day to see if it helped clinically or it helped her imaging, and it didn't, and that was for about a month. She had a photosensitive rash just briefly in summer 2022, but by the time she was actually referred to the ILD center, the rash had gone away. In terms of her past medical history, really not much, and she wasn't on any medications. She has a cousin who has rheumatoid arthritis, but there's no history of ILD in the family. And she works as a paralegal, so only an office job. She had no ILD exposures, and she's a lifelong non-smoker. Her initial investigations are posted up here. So her pulmonary function test showed an FVC of 59%, diffusion capacity of 64%, and that was unchanged despite the course of prednisone and had been unchanged for the course of the year. Her serology was strongly positive for ANA at 1 in 640, anti-Rho of greater than 8, and mitogen panel that was positive for PL12 and Rho 52. The 3+ really means strongly positive. And the rest of her serology was negative. So I'd like you to just sort of think to yourselves, what diagnosis would you say is suggested based on these clinical features? This was her imaging. So, and if you recall me saying that her imaging didn't change much on serial repeat scans, but if you can appreciate it, this was essentially reported. You could see reticulation that was mostly peripheral predominant and basal predominant. However, there's also ground glass that you can see that's associated as well, and it's not completely peripheral, and you can't really appreciate much in the way of subpleural sparing, but this was reported as overall most consistent with a non-UIP pattern, most likely NSIP. And because she wasn't really improving with immunosuppression, it was discussed, and a surgical lung biopsy was done of the right side, the right middle lobe and the right lower lobe, and this showed lymphoid aggregates with germinal centers and few fibroblast foci. And usually when we see lymphoid aggregates with germinal centers, we tend to think of that as being responsive to immunosuppression. And when we see fibroblast foci, we usually associate that with more of a UIP pattern or IPF, but it can really be seen in many diseases. So that just sort of implies some fibrosis. The overall impression was fibrosing NSIP. So if you can think about this, she was brought to multidisciplinary discussion. It was recommended that she at least be evaluated by rheumatology, and she didn't meet criteria for any specific connective tissue disease. Like I said, the rash was gone. She didn't have any photos of it, and it was just the positive serology as well as an NSIP pattern. So the things that we're always thinking about at MDD, and I'm sure you're thinking of this at your own, are, what are the clinical findings? What does the radiological picture suggest? And how do we put histopathology together if we have the benefit of having histopath? And then, of course, the first question always is, what's the most likely diagnosis before we even get to treatment? And so I just wanted to have a brief chat about this concept of interstitial pneumonia with autoimmune features, which really isn't a diagnosis. If you read the 2015 paper, they were very clear that this shouldn't be a standalone diagnosis. They're still unclassifiable, but they meet criteria for IPAF. And they're purposeful about that because it isn't. It just sort of helps us to better understand patients and group patients that used to be considered maybe emerging connective tissue disease. But we do know that many patients actually present with ILD first and then develop CTD after. So what we're looking for to come to this classification is they should have presence of an interstitial pneumonia, they don't meet criteria of a defined connective tissue disease, and you've excluded all other etiologies. And they should have at least one feature from over 2 of the following categories, from the clinical domain, the serological domain, or the morphological domain. And so the clinical features are kind of what you ask patients already, things like Raynaud's, palmar telangiectasia, mechanics hands, digital tip ulceration. But sometimes you're seeing these patients in your ILD clinic, and you're the first one doing this exam. They may not have seen a rheumatologist yet. When we're talking about serologic features, we're not talking about just the minor elevations in ANA at any pattern. We're talking about strongly positive ANA or any titer at a nucleolar or centromere pattern, because the features here are what have been shown to be most associated with a connective tissue disease, not just spuriously elevated. But I want to come back to this in a moment, because you'll see these antibodies, these myositis-associated antibodies that generally we think of when we think of anti-synthetase syndrome. And then when we're talking about morphologic features, we're really talking about NSIP, OP, or an overlap or LIP. That doesn't mean that you can't have fibrotic HP pattern, you can't have UIP pattern in IPAF. It's just not one of the sort of key points that gets you, or key features that gets you a point here. And so then we come back and we integrate this and think about, well, does this patient meet criteria for IPAF? Can we call this patient that? But one thing I did want to come to while you're thinking about that is sort of this idea of myositis antibodies. So this comes back now again. And so this was a paper out of the group at UC Davis. And what they did is they looked at myositis-specific antibodies. And those are patients that have these antibodies are quite specific for an inflammatory disease, whereas myositis-associated antibodies are often present, but not quite as specific. And they actually this was a very clever study. So they took patients who met criteria for IPAF, and they stratified them based on whether they had a myositis-specific antibody or whether or not they had a myositis-associated antibody, and they compared them to those with myositis, with other CTD, or with IPF. And they found that the people who had myositis-specific antibodies behaved very similarly in terms of overall survival to myositis patients, and those with CTD behaved very similarly to those with IPAF with a myositis-associated antibody, and those who had neither behaved more similarly to IPF in terms of their survival. So this is interesting too, because based on clinical experience at the multiple centers that this study was done out of, that they took patients from, they found that 75% of the patients with IPAF and myositis-specific antibodies were treated with immunosuppression, which kind of goes along with our clinical feel in a lot of the centers that we work at, that these patients may have more aggressive disease and may be more responsive to immunosuppression. So again, just to reiterate, those who have myositis-specific antibodies seem to have a similar trajectory to myositis-ILD, and those with myositis-associated antibodies seem to have a similar trajectory to other CTDs. So then when we're thinking about this, we may want to think about what therapies might be on the horizon for this patient. And I know that this will be no surprise to this group. The SLS1 trial, which showed that cyclophosphamide was superior to placebo in terms of improving forced vital capacity, and then SLS, the sequel, as I like to call it, the trilogy is going to be out pretty soon, showed that mycophenolate and cyclophosphamide both improve forced vital capacity, but there were fewer side effects in mycophenolate. So for the longest time, what we've been doing is we've been extrapolating this to all CTD-ILD, but there's been some new data out this year that's been really interesting. So the recital trial was one of the most recent trials that actually looked at more of a grab bag of patients, those with scleroderma, myositis, mixed connective tissue disease, and they randomized them to either cyclo or Ritux. And they followed them for, it shouldn't say 24 months, it should say 24 weeks, and they measured the rate of change of forced vital capacity. And if you look at the bottom graph, you can see that they both improved FVC by about 100 milliliters. And then if you look at the top graph there, the bar graph, there was no significant difference between the two. So this trial was important because it's an inclusive trial. It showed that both rituximab and cyclophosphamide were associated with improved forced vital capacity. And even though Ritux wasn't superior to cyclophosphamide, it was still an improvement and generally much better tolerated than cyclophosphamide. So then this has led to some other work in the new EVER-ILD trial, which was a morphology-driven approach to intensify immunosuppression in patients who were refractory. And so what they did here is, this was a grab bag of patients, again, those with CTD-ILD, IPAF, idiopathic ILD. They just had to have an NSIP pattern, and they didn't even need to have that on lung biopsy. In fact, the majority of people didn't. This was just on imaging alone. And they randomized them to either mycophenolate or mycophenolate and rituximab, and they followed them for 6 months. And, sorry, the lines are a little bit odd here, but if you can imagine an imaginary line through 0, which would be your sort of line of no effect here, you can see that those who were treated with mycophenolate and placebo, that red line there, they actually had a bit of a decline in their forced vital capacity, whereas those with rituximab and MMF had a bit of an improvement, and that the overall difference was statistically significant of 2.6%. So this told us that rituximab and mycophenolate is a reasonable option in people with more aggressive disease with an NSIP pattern. The caution here is infection risk, though. There were numerically more people who had infections in the rituximab group, the more intense immunosuppression group. And this is something to think about in our sort of post-COVID world where people are still getting sick. But this is helpful because there's an increasing emphasis on morphology to inform treatment strategy as a surrogate for biology. And then lastly, we have antifibrotics. So we have the Census trial, which showed that nintedanib was superior to placebo in attenuating FVC decline in scleroderma. And then in all of those patients with PPF, including CTD-ILD, it showed that, InBuild showed that there was an attenuation and decline in those patients as well. And that sort of led the 2022 update to suggest this new category of progressive pulmonary fibrosis, which would be 2 of 3 in the last year, worsening symptoms, worsening physiology, or worsening radiology. So one proposed way of how to sort of work through this and how we often conceptualize this, kind of using all of those tools that I described and some of those data from the studies, we take patients with CTD-ILD and we always feel that they should be referred to rheumatology, and especially those who are more of an IPAF type of flavor. And if they have a significant disease burden, so if this is a new referral and there's enough of a disease burden or they're progressing that we think that they should be initiated on treatment, our first step is really immunosuppression. So that's prednisone with MMF or Imuran. And then we're going to continue to follow them for 3 to 6 months. And if they do progress, we're kind of thinking of a couple of things. Do they have extrapulmonary symptoms that may warrant immunosuppression? Or do they have more of an inflammatory morphology? Or is the morphology mostly fibrotic and they don't have any extrapulmonary symptoms? And what I mean by inflammatory morphology is ground glass, consolidation, or an NSIP or OP pattern. And in those cases, we're thinking about more immunosuppression, like Ritux, TOSI, TAC, first making sure that they're optimized on their mycophenolates. And then from a fibrotic standpoint, we're thinking of reticulation, honeycombing, minimal ground glass, and those are the patients that we're treating with nintedanib. But it's really a spectrum, so you can kind of go back and forth between this treatment algorithm. And you may even want to consider upfront antifibrotic therapy now. And so the fibrotic morphology really should be predominant in these cases. So in patients who have UIP pattern fibrosis, for example, who have CTD, or who have meet criteria for IPAF, but things appear more fibrotic, if they already meet PPF criteria and they don't need immunosuppression for any extrapulmonary symptoms. So in this case, we called this NSIP. The final diagnosis was, unclassifiable disease, meeting criteria for IPAF, but we really felt like this was a flavor of emerging connective tissue disease. So we ended up suggesting mycophenolate with a low threshold to initiate antifibrotics if she progressed. And the jury's still out in terms of whether or not she will progress. She actually this patient declined treatment and preferred to be monitored just because her quality of life was still quite good, and she had about a year's follow-up before she saw us and things were stable. So we're cautiously watching. So just to recap on a couple of pearls, IPAF represents a recent paradigm shift in the spectrum of unclassifiable ILD to CTD-ILD. You can consider this when patients meet criteria for IPAF but don't have a formal CTD. But be cautious when you see myositis-specific antibodies and think about that. You can consider rituximab as a reasonable add-on option to MMF, but think about infection risk. And a morphology-driven approach we're seeing more and more in the ILD community. So imaging is becoming very important. And considering antifibrotics in patients meeting criteria for PPF.
So just before we crack into the case and to the question of kind of how many people participated in MDD, I just wanted to comment that, we're all pulmonologists, respirologists up here. At my center, just to tell you a little bit about the composition of who I work with. So we have MDDs every 2 weeks. They're an hour long, and we generally are able to get through about 6 to 8 cases. One of our first slides has an Excel spreadsheet we're happy to share of kind of how we input the data so the radiologists and the other clinicians know the cases ahead of time. And we have an excellent cardiothoracic radiologist, 3 interstitial lung disease physicians, we have a transplant physician, and we also have a thoracic surgeon that join us. We have a separate group of CTD, ILD, MDDs, so the rheumatology group does not come to our MDDs. But to the previous physician's question about biopsies and the risk, we actually have the ability to have the thoracic surgeon there and kind of give a quick comment. And for our center, anybody that's fairly young, and really anybody actually that we're sending for biopsy, we generally have the transplant team at least kind of know about ahead of time before biopsy, just given that very, very small chance of exacerbation, but just so that they're aware of them. Okay, so cracking on with the case. So I'm going to present a 62-year-old Caucasian male. No real significant past medical history, a bit of reflux is on pantoprazole. In terms of his history, so he was originally brought to the ILD center because the patient asked for a screening CT for lung cancer. He was a never smoker, but had a really strong family history of lung cancer.
Had some slow progressive dyspnea, didn't really have any exposures, no symptoms of connective tissue disease. He had no prior drug exposures. He did have a family history with a sister who required a lung transplant for fibrotic hypersensitivity pneumonitis. And then while I was caring for him, his mother was also diagnosed with idiopathic pulmonary fibrosis. Are these the updated slides? Okay. The workup, so when I saw him, he had reduced FVC, still within normal, and slightly reduced DLCO, and then this was his CT chest. Okay. Okay. Shoot. Okay. So here's a picture of one of this gentleman's CTs, and I'll just give a pause for everybody to take a look at it.
Maybe I can behave as a pseudo-radiologist up here for 2 seconds and at least throw my 2 cents out there. Yeah. So it seems kind of basal predominant and mostly peripheral, although there are some parts that are inching in centrally, more so ground glass than reticulation, but somewhat admixed from what I can see here. And there might be a bit of a hint of subpleural sparing on the right side, so perhaps more in keeping with an NSIP pattern.
Any other differentials that you've had on there?
Radiologic differentials?
Yeah.
Or, yeah, so in terms of, certainly if someone with a smoking history, you might consider something like this in something like DIP or smoking-related ILD. Infection is going to be on there. Maybe it's a little bit confluent for something like a post-COVID or post-organizing pneumonia kind of picture, but that might also fit the picture.
Okay, great, thanks. Sorry, this was supposed to be a poll question, but I think there's clearly a fibrotic pattern, most in keeping with an NSIP, but it's definitely some atypical features as well. He, as mentioned, had the CT chest labeled as kind of NSIP. He did go on to have a bronchoscopy, which showed, a very minor elevation in some inflammatory markers, nothing really to lead a diagnosis. And he had connective tissue disease serology that was all negative. So based on the clinical history and diagnostic testing, what would be the primary differential here? And so, he's got no clear cause for this radiographic NSIP. We talk about idiopathic NSIP. Again, I think this is a debated discussion, but usually we want a cause for NSIP. And given that he really had nothing else that was clear on his workup to suggest a cause, he was labeled unclassifiable ILD. In terms of, and I apologize, there were some updated slides, so I apologize if I'm pausing. So in terms of management, before he came to our ILD center, it was recommended that the patient be tried on immunosuppression based on the CT pattern. It was also recommended that they have a surgical lung biopsy because of this unclassifiable diagnosis, and the patient requested a second opinion. And so, pausing and you're seeing this patient for the first time, is there any specific questions you would ask them at their initial ILD assessment with the information to date? And so, sorry, can I go back? There's a pointer. Okay, so sorry, there's supposed to be a big box around here to say family history. We can't ignore this very clear family history that he has a sister and a mother who has idiopathic pulmonary fibrosis. So family history considerations, and kind of coming back to what you would ask this patient. Number one is, who is affected within the family with pulmonary fibrosis. So the definition of familial pulmonary fibrosis is 2 or more, usually first-degree relatives. There's some European guidelines that say maybe they can be second-degree relatives. But when you're creating that family pedigree, you really want to go back at least 3 generations asking if anybody has any pulmonary fibrosis. In this case, I think it highlights that there was this lung cancer history as well. And, a lot of times people say, oh, they didn't have pulmonary fibrosis, but they died of COPD, or they had heart failure. So, it's hard to, for patients, especially when we're dealing with rare diseases, say 50 years ago, to say that somebody died of pulmonary fibrosis. So anytime somebody's died of any lung disease, it certainly makes me pause and think, could this be something that's running in the family? Imaging characteristics is also important. So this slide just shows that within a family, not all CTs are the same for that family. So in my case, the patient, one of the sisters had hypersensitivity pneumonitis. This patient had radiographic findings of NSIP. So it's really important to note that not all family members are going to necessarily have the same type of ILD. In terms of the clinical history, coming back to the question of what you would ask them on their first assessment, early graying, so we generally think kind of around the age of 30 if somebody's gray, this would be considered early graying. Hematologic malignancies, in general, bone marrow failures, so anemia, thrombocytopenia, MDS history, as well as liver disease. And then I also would comment on lung cancer as well, given some of the surfactant genes that can increase your risk of lung cancer. And then finally, if they've had genetic testing, and we'll talk a little bit more about this. So I would be remiss not to mention this paper, and you'll probably see it a couple of times over this summit. But the Pulmonary Fibrosis Foundation actually put together a working group to discuss genetic testing and the role of it. And I think it is important to comment that I'm from Canada, and so access to this might be a little bit different. But I think no matter where you practice, patients do have the ability to do some commercial testing by themselves, as well as kind of healthcare-directed testing. Before embarking on clinical genetic testing, I think it's important to take a pause and think about, how is this going to change my management? What is the clinical utility of this? The access to testing, meaning is this something that the patient's paying for out of pocket and they can run upwards of $2,000? Access to medications is a really important question. Before the InBuild study, we had to have a IPF diagnosis with UIP to access things like pirfenidone or nintedanib. That's really changed in the past couple of years, but it's also important to think, if this genetic testing is going to change your access to medications, depending on the results. And then I think the biggest one here is access to genetic counseling, making sure that you've got a team around you to counsel not only the patient, but family members that might have questions. Sorry, there's a slide missing here, but and the guidelines address this. They really clearly say that really making sure that if you are going to pursue genetic testing, it's going to change your management, it's going to risk stratify the patient, risk stratify the patient's family members before you kind of embark on this. So the next question is, does the type of interstitial lung disease matter if you have a diagnosis of familial pulmonary fibrosis? And I think it's important to say familial pulmonary fibrosis, I think of it more as a phenotype as opposed to a diagnosis in itself. And part of this reason is because familial pulmonary fibrosis, I've already shown it can be heterogeneous within a family, but it's uniformly progressive. So I'll just highlight one paper, and there's a couple out here that describe this. This is in a cohort of patients that had telomere-related gene abnormalities. And what this paper looked at was the clinical diagnosis based on the type of telomere gene abnormality that they had. So just highlighting TERT, which is kind of one of the more common telomere gene that can be abnormal, you can see here that 50% of patients with a TERT mutation had an IPF diagnosis, but there were still lots of other diagnoses here. For example, 11% had chronic hypersensitivity pneumonitis. So the clinical diagnosis is not completely determined by the genetic variant. Also importantly, survival is independent of imaging or an MDD diagnosis. It's much more related to that genetic variant. So on the left-hand side, you can see that the different types of genetic abnormalities, they all had a progressive phenotype. And on the right, you can see patients separated into IPF versus non-IPF diagnosis, which we'd usually think had a better prognosis. They had very similar prognoses. So sometimes the genetic variant can kind of trump that clinical MDD diagnosis. Management considerations. So in our case, I think it's important to consider early antifibrotic therapy. We've shown that there is a clinically progressive phenotype in familial pulmonary fibrosis cases. You'll see probably later on this summit data that shows that short telomeres can actually influence patients' response to immunosuppression, and therefore that should be used judiciously. Earlier transplant referral is indicated given that they do have a progressive phenotype. I do investigate for hematologic abnormalities and liver disease, and I follow these patients a bit more regularly given that progression risk, and I do consider family screening. So in terms of family screening, in cohort studies, interstitial lung abnormalities have been seen upwards to a quarter to a third of family members. These are unaffected family members, and if you screen them with a CT chest, ILAs can be present in up to a third of them. Of those patients, or I should say participants, who have ILAs, ILD, diagnosed by imaging or abnormalities in their pulmonary function testing, can be seen in over 50%. And this is similar incidence in a familial and sporadic cohort of people with idiopathic pulmonary fibrosis. So I think this is going to be the next wave of patients or participants, I guess you could say, that we're going to be dealing with, that I think that there is a role for screening family members, especially if there's a strong family history, and screening with CT is probably what I would advocate for. So the pearls from this is that familial clustering of ILD is common. We think it happens in about 20% of ILD cases. However, most cases of ILD do not have a monogenetic cause, meaning a clearly identifiable gene abnormality. And of those cohorts that do have familial pulmonary fibrosis, we actually can only identify a gene in 20 to 30% of those families, meaning there's still a lot more work to be done before understanding exactly what familial pulmonary fibrosis is caused by. I've shown imaging patterns can be indeterminate and are not necessarily the same in each affected family member. In terms of investigations, I do a complete blood count, liver function testing, genetics testing if available, and lung cancer screening when appropriate, again, depending on the family history. In terms of treatment, I do tend to use antifibrotic therapy with the caveat that if a patient does have a clear, for instance, connective tissue disease, ILD, then immunosuppression would be appropriate. And then I do make earlier transplant referrals. And then I do consider screening family members, although this is still, I think, something that we're doing a lot of research and learning a lot about. So for my patient, this was his track record of pulmonary function testing. You can see that he did have a decline in FVC, again, still within normal, but very clear 20% drop over 2 years, which would be considered significant. He was started on OFEV. A transplant referral was deferred at the patient's request. I see him every 3 to 4 months, and he has no immediate family members for screening.
Hi again, everybody. I'm Carrie Aronson. Thank you again for having me here. I'm going to take you through one of my cases. I want to make it as interactive as possible, but we'll also be, I think, mindful of the time. So I'm going to talk about a patient that I'm actually just saw not that long ago. So this is sort of like an active case, which I think makes it better and helpful because I can also hear what everyone here thinks. So where I am at Cornell, just to give an idea, we do like different types of MDDs. We have about one every week. One is just with radiologists, because as you can imagine, and we've spoken about a little bit, we have less pathology to look at. And so a lot of times we're sort of deciding on the procedure. And I say the MDD is like the decide on your procedure moment. Are you going to do one or not to get more information? So we have about 3 times a month we do that. And then we do with pathology on average once a month, sometimes more if we need to. And with multiple centers across the city join in, so it's actually very nice. This gentleman that I saw not that long ago in clinic, 60-year-old man, originally from India, who had an incidentally discovered ILD. So I'm sure we've all had this sent to us, like nodule screening or some like cardiac CT, right? They show up and they're sent to us because someone found ILD on the scan. And so he had past medical history of type 2 diabetes, hyperlipidemia, some hypothyroidism, and some reflux. It's like not so bad, he says. On review of systems, he says he does occasionally cough with eating, but his reflux is actually pretty well controlled. And I did a pretty extensive room review of systems, which was negative. He is a former 20-pack year smoker, and he quit in 2012. As I mentioned, he's born in India, and he moved to the U.S. 30 years ago. He works as a car salesman. So no specific exposures, he says, within that environment that he works. And so he lives in a home in Queens, and then he also stays at his parents' home sometime in New Jersey. And I asked him specifically about those locations in terms of water damage, mold, mildew, the whole exposure, you know, hundreds of questions long that we spend a lot of time doing in our clinic. And he denied everything. Another thing we ask everybody in New York City specifically is exposure to 9/11 below Canal Street. That's in all of my histories, and that was a no for this gentleman. And then family history, as we just heard, you know, a great case and talk about family history. I asked about all the things that we would consider as potentially associated with familial pulmonary fibrosis, and that was negative. So moving on, we did have pulmonary function tests on this patient, so you can see some mild reduction in the vital capacity and diffusing capacity. Mind you, I should say, I forgot to say, he's completely asymptomatic. I didn't even say that, but this gentleman is completely asymptomatic, incidentally found. And then I did a very extensive ILD workup, as a lot of our patients, because they are referred to our you know, tertiary referral center. They sort of, it buys them this large workup. And so for this gentleman, and you'll see why too, with the CAT scan, I did a pretty extensive workup. And so we had, you know, sort of a mildly elevated ANA and this like P-ANCA that I don't know what to do with, 1 to 80. And then this HP panel, which I think we could spend 2 hours all talking about together, the utility of that. Yes, I sent it. Some centers don't. And it came back positive for these two specific possible exposures. And so this is the CAT scan, which I also realized might not be in sequential order when you look at it, but I'm sure we can sort of see where the apices are here and the heart. But you can see we reviewed this with the radiologist, and it was sort of not a very typical, the conclusion was that this was not a very typical pattern of anything. You know, he sort of has some anterior upper lobe findings with some ground glass and fibrosis, and then as you go down, like there's some peripheral findings, but not like a significant amount. And then as you go down towards the bases, sort of that right base, you know, has some, again, ground glass fibrosis, maybe a little more central, maybe more than the left side. And so, you know, the conclusion and sort of what I always push the radiologist on first is this a UIP pattern or not? That's what I want to know. And I think we all probably agree, right? That we want to know, is this probable or definite UIP or something else that we can say it definitely looks like, or do we not know? So the conclusion was like, we don't know what this is. And so that was the conclusion after the discussion with the radiologists. And so with all that information, sort of the clinical information and this, then the next discussion was, well, what do I do to help figure out what the diagnosis is? And so this is when we really started discussing the utility of a procedure. In particular, you know, should we send this man for a surgical lung biopsy? And so the consensus in MDD, and I'd love to hear what anyone on the panel thinks, the consensus was that we should send this patient for a surgical lung biopsy because I did not know what diagnosis to give this gentleman. I don't know if anybody has any other thoughts on the panel, but I want to make this more.
I feel like this is a to biopsy or not biopsy MDD session.
Yeah.
which is what all our MDD sessions are.
Yeah, I think it's so important because I would love to not have to do it, but yeah, go ahead. Yeah, I didn't include that. There was not one on the first, but then I repeated one and there was not really air trapping. Yeah, that's a really good question, yeah. Right, so yeah, he didn't have, there was no bronchoscopy, nothing done yet. This was sort of after the first visit. So that was really the next discussion. I actually forget what my next slide is, so I'm gonna go to it and hopefully that'll be something, oh good. Okay, I showed this earlier in the talk, sort of this like, just going through every case systematically, right? So could this patient have IPF, like walking into the office clinically? Maybe he fits the age demographic, some of sort of the medical history of that, right? But certainly based on what we see in the CAT scan, it didn't look like a UIP pattern, at least on the CT. So now we're starting to entertain other diagnoses. And so we discussed with our radiologist, this looked indeterminate, right, for UIP or potentially alternate diagnosis. And so the next question is, what do we do? And so the consensus here was to do a surgical lung biopsy because we'd be able to get larger pieces of tissue to look at the pathology in 2 different locations. However, the other avenue, you mentioned bronchoscopy, is also obviously another thing that we can consider doing, understanding the limitations. And I think that that's where this MDD discussion and also the discussion with our patients is really important because obviously the risk and benefit is different for each procedure. And so I came to my patient, and remember, this is a man who incidentally had ILD found, who has no symptoms, and is like, I don't want to have a surgical lung biopsy. So I talked to him about the alternative, doing a bronchoscopy. And with transbronchial biopsies, we all know they're like very small pieces. They get smushed, and often the pathology, in this case, I was worried would not be very helpful, and I told him that. But certainly with HP and other sort of inflammatory things on the differential, I thought, okay, we could potentially have a cell count that's helpful. And then I discussed with our proceduralists, we have very good IP proceduralists, which I think not everybody has access to that, so this may be a limitation, about a potential cryobiopsy, which how many people here have cryobiopsies performed in their patients? Yeah, great. So I think, so the patient declined. I said that. Okay. So we talked about the sort of, I forgot what the slide was. I'm so sorry. The surgical lung biopsy. So we recommended it, and we already talked a little bit about some of the risk and the benefit. I thought in this gentleman, he had good performance status. He could have sent him to the OR. I think, in retrospect, now that we have a bunch of information, maybe it wasn't necessary, which we'll get to. But I think if we would have sent him, it would have been a fine decision. But he didn't want to do it. And so then we discussed doing sort of other modalities. So everybody's maybe heard of this study before, sort of the utility of cryobiopsy. I think the formal ATS recent recommendations are not really like for or against doing this. It's really, do you have the expertise at your center? And it's not just the procedural expertise, but also the pathologist that's comfortable reading the cryobiopsy results. And so we are fortunate we have a pathologist who is interested and is good and comfortable at doing it. And so in this case, we actually opted for that. He had, very low bleeding risk at baseline, didn't really have a lot of emphysema, things that we would potentially worry about. And so in this study, the cryobiopsy compared to surgical lung biopsy in this cohort of patients, it was sort of, the cryobiopsy was basically seen as good enough or as good as a surgical lung biopsy. But of course, that's very center dependent. And so I have these beautiful slides that I got from our pathologist. And so they were actually able to get biopsies from the right upper and right lower lobe. So the right lower lobe was sort of like non-specific. And I only have the sort of larger magnification views. So septal thickening with fibrosis and chronic inflammation in the right lower lobe. However, in the right upper lobe, she was very excited when I reviewed this with her. She said there's evidence of chronic bronchiolitis and peribronchial metaplasia with fibrosis. And when you zoom in, and you probably can't even see it really well on this slide, but there is a fibroblastic foci there, and there were several on different pieces. And she also found an ill-formed granuloma. And so this was her, I basically just pasted this from what she said. But essentially she said, the right lower lobe was pretty nonspecific, but that right upper lobe, she did see chronic bronchiolitis with peribronchial metaplasia and ill-formed granuloma, patchy interstitial fibrosis, and a fibroblastic focus. And so she said this could be potentially, suggestive of a fibrotic HP in the right clinical setting, of course, because there's limited samples, these are small, right? Of course, all the things we knew we were gonna get from not having a surgical lung biopsy. But this sort of brings up the next thing, right? So I still don't, based on this, right, I still, just with this information, couldn't 100%, and we'll get into, I think, maybe the diagnostic guidelines for HP. I think it's possible, that's definitely on the differential. This is very interesting, right? It came from the upper lobe. He has a CAT scan that potentially, could have some features of that. He had that HP panel, which we can get into if that's sensitive or specific at all. He didn't have any exposures, but certainly I didn't force him yet to have his home inspected. And so the next thing that we also sent, how many people have ever sent an Envisia or no? Yeah, okay, great. So this was actually a case where I thought it was useful. And so, for everybody that isn't as familiar, so the Envisia is a genomic classifier. And what it is it's basically looking for the signature for UIP. And it's from a transbronchial biopsy. And so it has a very high specificity. The sensitivity is not great, right? So if it's negative, it doesn't necessarily rule out that there's UIP there. So in the guidelines, it's not, I think in the guidelines, actually the group was split, like half for using this, half against. And you know, sort of the way that we practice at Cornell is in the right clinical setting, it could be useful. So this gentleman is someone that I had a very low sort of pre-test rate prediction that he had UIP based on everything else. And so for me, when that came back negative, I feel more confident that this is not UIP. So this was helpful to me to sort of make me lean towards these other diagnoses or patterns that are not UIP. And I would love to know what everybody else thinks about all of that. I don't know if I can go back. Oh, yeah. And just so you know, the lavage was interesting, 8% lymphocytes and 79% neutrophils, so very inflammatory lavage, but not with lymphocytes. All the cultures were negative. And so we're sort of going through this process again, right? We had indeterminate, we did this BAL and transbronchial biopsy. I think there's an alternative diagnosis from IPF that I'm feeling more confident with based on this, but what the actual diagnosis is, I don't know. And so, you know, then I think that's where we can like sometimes be helpful, it can be helpful, right, to go through these new guidelines that we have for HP, where they can be very busy, but say, for example, I actually went back to the radiologist and she looked at the CAT scan, she goes, I could say there's maybe some central lobular nodules there. I was like, oh, okay. And so say, for example, if we really did think that this was the high res was compatible enough with HP, if I really can identify an exposure in this patient and we sort of have some pathology that's reasonable enough to make us think about HP, you could even maybe say that this is high confidence. I don't think we're there yet with this patient. I think we need more information. I'm sort of more moderately confident to maybe low. And so that's where I am with this patient. I don't have an answer yet, but I just think it's good to sort of bring up the discussion about these procedures and how they may or may not help us in this situation. I think this is my last slide, so I'd love to hear from the panel if you have any other thoughts or